One, go. We are live now, ma'am.
Yes, thank you. Supriya, please start.
So a very good evening to all of you who are present here. And today, Indian Society of Perinatology and Reproductive Biology cordially invites you for the episode 4 of Seed to Bloom series, that is Fertility Enhancement Committee of ISOPAB in collaboration with New Delhi, Burla Samalpur, Lucknow, Vijayawada, and Kanpur city chapters of ISOPAB. So the chairperson is Dr. Lakshmi Srikhande, madam, and she's also the convener, and I'm the co-convener of this series. And may I have the next slide? So to begin with any auspicious event, we start with the Ganesh Vandana. So can we have the prayer?
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि
You
Thank
can
you.
skip this slide, yeah. Yes.
So we have got our chairperson. She's also chairperson of ICOG. Madam, you want to play this again? Okay.
No,
Just
let's have lamp lighting. Invite all the dignitaries. Virtual
Yeah.
invitation, yeah.
Yeah, so may I request the President Secretary of National ISOPAB and all the dignitaries, the speakers on the dais for the virtual lighting of the land and inauguration of the
Dr. Mishra,
function.
yes.
Thank you, Madam.
Yes, Pratya is here. Please introduce her and invite her for her comments. Maji sir will join in between and we will have his pearls of wisdom whenever he joins. Yeah.
So first of all, I would like to invite the Secretary General ISOPAB, Dr. Pragya Mishra Chaudhary, who is also a consultant in fertility specialist at New Light Festive Baby Center, MGM Hospital and Research Center. She is at present the Secretary General of ISOPAB. She was the Chairperson Genetic and Fetal Medicine Committee, POXI. She has been also the Founder Secretary of Bihar Chapter of ISAR, Vice President of Patna OBG Society, and she has held many posts in the office of Patna OBGYN Society. Recently, she has been the examiner for MRCOG clinical examination, and she has been awarded with many awards, gold medals to her credit. And she has got a great organizing capacity and skills. She had been organizing the many national and state level conferences. So over to you, Pragya, Dr. Pragya.
Yeah.
Pragya Di, we want to hear from you.
Yeah. Good evening to all those who have logged in, the faculty and all the delegates of today's series, which is the fourth series of Seed to Bloom, and the chairperson of Fertility Enhancement Committee, who is Dr. Lakshmi Srikhande, is coming up with such a great program every 2 months. And it's although it falls on a weekday, but I don't like to miss the program because the topics and the speakers and the panel discussion, every time, she comes up with something which is so tempting and so important for our day-to-day practice. Because just last week I was struggling with a patient with adenomyosis, and that's why I'm so keen to hear Dr. Shameen today. But perhaps I may end up missing her talk. I'm not sure. And so, chief guest of today's function, Dr. Manju Geeta Mishra, and guest of honor, Dr. Usha Sharma in absentia, and President ISOPAB, Dr. Arup Kumar Maji, co-convener of today's Seed to Bloom series, Dr. Supriya Jaiswal, and all the faculty. Speaker, I can see Dr. Sampath Kumari, who is such an erudite speaker, and second speaker, who's Lakshmi Shri Khande. And I think Dr. Sampath Kumari is going to moderate a panel on ESHRE guidelines, which again are very important, for our practice. I know it's sometimes difficult to adhere strictly to guidelines because, we have to treat our patients on an individual case-by-case basis. But it's always good to know what the well-recognized guidelines they say about a topic. And our international faculty, Dr. Shameen, Dr. Lakshmi, I must thank you for involving one international faculty every time in your program, because that's how we get to know what others, what people are practicing in other parts of the world. So I can just say thank you for giving ISOPAB such a good program every time, which you are arranging every 2 months, and especially the ones who are interested in infertility, they would definitely benefit a lot. I can see Dr. Kiran Sinha, Dr. Uma Singh, Dr. Lata Karup, and Dr. Neelam, who are all the city chapter presidents and secretaries of ISOPAB. And they're all working so hard, just yesterday in a conference which was organized by Patna chapter of ISOPAB, I said that, ISOPAB has established a very prominent place in the map of all the professional organizations in the country. Because, we have almost 3,400 members and 39 city chapters. But my vision for ISOPAB, in the next 10 years would be that we have at least 5 to 6 city chapters in every state of the country. That's how, we are going to reach ISOPAB to the doorstep and improve the perinatal mortality and morbidity of India, which is still high. So thank you very much for informing me for all these Seed to Bloom series. And I'm very happy, that you've given me the opportunity to speak in front of such an erudite set of panelists and faculty. So thank you so much.
Thank you, Pragya. Thank you so much. And that is the whole idea, to have constantly one international faculty so that we have exchange of knowledge between India and the other country, what they are practicing. And in every Seed to Bloom series, we are having collaboration with 5 city chapters to reach out to all our members and to increase the participation from the chapters of ISOPAB. So I'm so happy that you have logged in. And I know mainly we talk about maternal morbidity and mortality, but ISOPAB is concerned with reproductive biology as well. And now WHO has considered infertility as a disease. So according to the objectives of ISOPAB, this Fertility Enhancement Committee is trying its level best to come out with the solutions and the resolutions as far as this reproductive biology aspect of ISOPAB is concerned. So thank you, Pragya. Thank you so much. Supriya, please invite the chief guest here.
Yes. Can I have the CV, Saiti?
Yes.
So, our chief guest of today's Seed to Bloom series is none other than the backbone, actually, I can say, a living legend, Dr. Manju Geeta Mishra, who is also the past president of ISOPAB. Actually, she is the person behind the success of this ISOPAB. She had been involving many people and have backed people like anything for any program, wherever you want. She had been the past president of many of organizations like IMA Bihar State, of All India Doctors Wing, that and she is also the president of ISOPAB and then P Patna OBGY Society. Madam has a huge CV. She had also been the chairperson medical education of Foxy, committee of Foxy, delivered so many orations in national and even in the international conferences. She has written so many books and for Foxy publications like Critical Care in Obstetrics and first and second edition, and many things to her credit. Madam has been a BC Roy awardee and lifetime achievement award from many societies. Madam is a very generous, very versatile personality who helps everyone, and she's a mentor to many people, PGs, and even the teacher of teachers. So, Madam, with these words, we are very grateful to you for that you have accepted to be the chief guest of today's program. Madam, kindly bless this webinar today.
इनको अनम्यूट करो साहिती, मैडम को अनम्यूट करो। मैडम आप अनम्यूट नहीं हो। साहिती तुम कर सकती हो तुम्हारे एंड से अनम्यूट मैडम को।
I'm trying.
यस मैडम प्लीज।
हो गया मैडम।
Very good evening to all of you. First of all, the Arup Majhi, the president of ISOPAR in absentia, Secretary General Dr. Pragya Mishra Chaudhary, and all the convener Dr. Supriya Jaiswal, and especially the backbone of this program is Dr. Lakshmi Sri Khande. I must thank Dr. Lakshmi Sri Khande because she is the person who has started this committee in the ISOPAR. Only on her request, the committee was there. It was started in the ISOPAR, and I must congratulate Dr. Lakshmi Sri Khande because she has. She is doing so many programs, and especially she had started the Seed to Bloom series. And in this Seed to Bloom series, in every program, the new topics are being discussed. And all those topics are very related to the infertility. So this time, the subject she had chosen is the endometriosis. And as we all know that endometriosis is very important, which is one of the most important factors which lead to infertility. And today, and in every Bloom series, so she invite one of the international speaker, and all the members of ISOPAR are benefited by this Bloom's series. So thank you very much, Dr. Lakshmi Sri Khande. I must congratulate you that you are regularly convening this Bloom series. So and it is very informative, and all the members of ISOPAR are benefited by your program. Thank you very much. And actually, you insisted on you must have this committee. Previously, for this committee. Otherwise, in the beginning, there was no such committee was there. Fertility enhancement committee was not there in ISOPAR. So thank you very much for conducting all these programs. And I think all our members will be benefited by your programs. So thank you very much.
Thank you, madam. Thank you so much for your generous appreciation, and also for starting this new committee in ISOPAP, that is Fertility Enhancement Committee. And also thank you so much for your personal presence and pearls of wisdom. So thank you so much, dear madam. And Supriya, let's start with our scientific deliberations. Yeah.
Yes. Thank you, madam. Thank you for joining. Thank you very much. So now we start with the first session. The topic that is going to be there, that is management of adenomyosis with infertility, how far we can go. The speaker is none other than Dr. Sharmeen Abbasi. And to chair the session, we have Dr. Dilip Kumar Sarangi, who is President, ex-Director, Health Services, Government of Odisha, past President, Rourkela OBGY Society, and President, ISOPAR Burla Sambalpur Chapter, President IMA, Sundarbag branch, and President Rotary. So he is a very active member of our ISOPAR. So welcome, sir. The next chairperson is Dr. Satyanarayan Behera. He is the Assistant Professor Vinsar Burla, and he is also the Secretary, ISOPAR Burla Sambalpur Chapter. So over to you. Welcome you, sir, and over to you, the chairpersons, to introduce the speaker.
Thank you, Supriya ma'am.
Yes.
Good evening, Pragya ma'am. Pranam to Manju ma'am. And thank you very much, Lakshmi ma'am and Supriya ma'am, for heading us in this fourth Seed to Bloom series. Burla chapter indebted to you. Adenomyosis along with endometriosis are important causes of subfertility, but both are different as per impact on fertility and management of this subfertility. To shed light on adenomyosis, we have Dr. Sharmeen Abbasi from Bangladesh. She is joining from Toronto. This is the Ambassador World Endometriosis Society. Can I have the CV?
Yes,
Yes,
it's projected. Dr. Dilip, can you see it? It's there on the screen.
No, I am not seeing the CV.
No, then there is some problem with your internet.
So do we have the other chairperson?
Huh?
No, it was visible. Yeah.
Yeah, it is there.
Yeah. Dr. Sarangi, can you see it?
No, I am not seeing it. Supriya,
Okay.
ma'am, you can read through.
Yeah. So, Supriya, you introduce Dr. Sharmeen and let her start her talk. Yeah.
Okay, so Dr. Sharmeen Abbasi is Advanced Diploma in ART Fertility Specialist and Associate Professor, AKMMCH. She is the Ambassador of World Endometriosis Society, Ambassador of ASEA, Secretary International Androgen Access and PCO Society, SIG, Scientific Secretary of Endometriosis Adenomyosis Society of Bangladesh, and Fertility Preservation Society of Bangladesh. She is also the National Coordinator of School-Based SRH Awareness Programs and Voice of Endometriosis, Advisor, Vigo Scientific Committee Conference. Then she is Joint Secretary, PCOS Club of Bangladesh, Publication Secretary, Pediatric and Gynecology Society of Bangladesh, and Co-Chair Young Fellows Committee of Bangladesh Chapter, Reviewer of AOFOG Journal, Curious Journal of Medical Science, International Editor of many journals. She is also the Executive Editor of COVID-19 Environmental Health Guidelines and Dengue in Pregnancy Guidelines in Bangladesh. She had authored chapter in Demystifying Endometriosis, Contribution of Labor Room Management Protocol of Bangladesh, and National Guideline on Prevention of Mother-to-Child Transmission of HIV, Hepatitis, and Congenital Syphilis in Bangladesh. Best Speaker Award she has been conferred upon by CEPFOG, AFOG, OGSB, and Fusion Fertility Conference. Shan and Ratnam Young Gynecologist Awardee, more than 28 national and international publications, and more than 50 papers presented in different national and international conferences. Madam has moderated regularly every week in Women's Health Awareness Program in social media and print media. She's also a member of so many organizations like ASFP, Aspire, BCPS, and many more. So over to you. With a huge CV, we expect to hear a very good lecture from you, Dr. Sharmeen. Over to you for your presentation.
Thank you, Dr. Supriya, for your nice introduction. And the Honorable Chair of Session 1, Dilip Sir and Satyanarayan Sir, greetings from me. And I want to give my respect and gratitude to the National President of ISOPERB, Secretary General, and the past President of the ISOPERB. And my heartfelt gratitude to Lakshmi Madam. Lakshmi Madam is a name who is the inspiration of the many young gynecologists of Bangladesh, due to her regular academic activity and very sound scientific activity. So my respect and gratitude always for you, Madam, and very much thanks to give me the opportunity to talk in this important session. And every 2 months you arrange this sort of the session. I think it is fantastic and very much helpful for the young generation and the young doctors to get a guideline for the evidence-based guideline of the management of many gynecological and obstetrical diseases. So again, thanks to the organizer and very especially to Dr. Lakshmi Madam. So I will talk in adenomyosis and infertility, how far we can go. Actually, adenomyosis, this is a disease which is potentially missed, neglected, and it is also a disease which is inappropriately managed in many sort of the setup. The adenomyosis, which is first described in 1860 German pathologist Karl Born, and then it is published in 1896 by a gynecologist in his book Adenomyosis of the Uterus, that is published by another gynecologist who is Thomas Stephen, and he first introduced adenomyosis, that is today we know about the adenomyosis. The definition of the adenomyosis, which is particularly the histological definition, because presence of endometrial gland and or stroma outside the uterine cavity is talk about the adenomyosis. The incidence of the rate of the adenomyosis is widely variable because a study over the last 50 years, the prevalence of adenomyosis among consecutive hysterectomy patients, that is range from 8.8% to 61.5%. And its prevalent rate is higher in those cases, that is recurrent pregnancy loss, previous ART failure, adenomyosis that is diagnosed as a primary finding, that is de novo, in 80.6% of the infertile patient. So in the large study, they showed if the patient is more than 40 years of age, the chances of the adenomyosis is 24 to 30%. And if the patient have less than 40 years of old, the chances of adenomyosis or the incidence of the adenomyosis is 10 to 15% to them. This is an important slide, that what future is waiting for us, because the new thing that is approached by the different large data, they are talking about that up to 2023, the incidence of the adenomyosis increases, and also the cost of the adenomyosis in a rate of USD is 0.32 billion. And in 2032, it will be in 0.52 billion. That means it indicates the growth rate of the patient and also the treatment opportunity and the treatment cost. These all are together will increases. And the increases vulnerability is due to the aging population, menopausal women, rise in demand from emerging economy, increase in technical advances, and demand for the novel therapy across the globe are the key market driver that enhancing and appropriating the approach to the adenomyosis. And this is one of the important slides. It is show about the Asia Pacific region construction, because in Asia Pacific region, the adenomyosis will increases in over the 10 years in future. And this is due to the expanding awareness regarding adenomyosis, where the Asian Society of Endometriosis is hardly work, and also the World Endometriosis Society is hardly work among the Asian region. And also for the India, it is stated that Indian adenomyosis treatment market was the fastest growing market in the Asia Pacific region, because they showed in their largest study that in the Asian region, in India, it is properly diagnosed in maximum cases. And in maximum cases, the treatment approach is appropriate, and which will increases the cost value of the patient also. So in American College and FIGO, they are included the adenomyosis as a part of abnormal uterine bleeding. So pathology is very important when we are talking about the reproduction, when we are talking about the ART on adenomyosis, or when we are talking about the implantation rate of the patient of adenomyosis. Because growth of adenomyosis depend on estrogen circulation in the body, and that the theory included invasive tissue growth, stem cell origin, developmental origin, uterine inflammation related to childbirth, and the vaginal injury. The most important thing is spiral vessel angiogenesis, because adjacent smooth muscle hyperplasia and hypertrophy is also very important for this sort of cases. And also invagination of the endometrium alongside the intramyometrial lymphatic and embryologically displaced pluripotent Mullerian remnant is very important for the pathology of adenomyosis. So abnormal genetic and epigenetic factor, which we should keep in our mind, the estrogen and progesterone receptor dysfunction, promoting the cell proliferation, migration, differentiation, epithelial mesenchymal transition, And as a result, inflammation, neurogenesis, fibrosis, and neuroangiogenesis proliferation. These all work together for the progression of adenomyosis for the patient. And this is a very, very important slide because the potential relationship between environmental endocrine disruptor exposure, this is a very burning issue all over the country because the environmental pollution is increases. So environmental endocrine disruptor exposure and the development of endometriosis and adenomyosis. Here is a genetic variation, epigenetic alternation, steroid responsiveness, and as a whole fetal origin of the adult disease. That is, the embryo is grown through the adenomyosis mother. There is a chance of fetal origin of an adult disease of adenomyosis for this sort of patient. So environmental toxicant acts as the endocrine disrupting chemical, especially dioxin, phthalates, the bisphenol, and there is a parabens, which are acting as a pathognomic factor for the formation of adenomyosis. And endocrine disrupting chemical can be divided into two groups: persistent organic pollutants and the non-persistent endocrine disrupting factor. So when we are profiling the patient, we should keep in our mind the age of the patient, the pregnancy rate of the patient, that is high percentage of the multiparous women. But in our day-to-day activity, we are getting many adolescent adenomyosis in this time of the patient, and also the patient who are infertile with that adenomyosis. So I think the profile of the adenomyosis and the pregnancy relationship is little bit changed in last decades. Uterine surgery history is important, ectopic pregnancy is important, and those patients who are taking antidepressant, we should take the medical history, very important in here, because over-regulation of the uterine prolactin receptor messenger RNA that leading to adenomyosis that should kept in our mind. And the breast cancer, researchers have identified patients treated with tamoxifen have an important factor for the development of adenomyosis. So in clinical presentation, the classical presentation is chronic lower abdominal pain, menorrhagia, dysmenorrhea, and dyspareunia and infertility. But there are a large amount of the patient who are asymptomatic. When we work up for the fertility management, we can get this sort of patient as a diagnosed case of adenomyosis. We should not miss the association, because coexistence is very important for this sort of the patient, because there's a coexistence of endometriosis has been reported 50 to 60% cases. Leiomyoma may be present in almost 50% cases, and other reported association include endometrial hyperplasia, endometrial polyp, and endometrioid cancer of the endometriosis. And there is a very important correlation that is here. The patient who is suffering from DIE have a strong association, have the focal adenomyosis, that is 66.3%. And the patient who have a OMA, who have a very strong relationship to have the diffuse adenomyosis, that is 45.2%. So endometriosis, especially endometrioma and DIE, that should kept in our mind when we are dealing with this sort of adenomyosis cases. And the next slide, that is classification. The staging of adenomyosis is also important to manage the patient in perfect way, because stage 1, that is limited to the submucous of the uterus. Stage 2, when the myometrium is involved. Stage 3, it is spread up to the subserous level. And stage 4, beside the uterus, the pelvic peritoneum, adjoining organ, and involved in the pathological process. So perfect management, if we want to need, we need to classify the patient, we need to staging the patient in perfect way. So diagnosis, that is the first step of successful therapy. Achieving the right diagnosis is probably the most important task of the physician. Without the right diagnosis, the choice of the treatment only the guess and to do the treatment of the patient. The right diagnosis allow the physician to present to the patient the right choice of the available treatment, and to determine together the right therapy to the right patient is a prerequisite for the reproduction success for the patient. So the major problem of the treatment of the adenomyosis is diagnosis, because if you do not think adenomyosis, you will not find adenomyosis. And differential diagnosis with a major and very common other uterine disease should kept in our mind. Transvaginal sonography have a good sensitivity and specificity for the diagnosis, but MRI imaging is highly accurate in the diagnosis of adenomyosis. Hysterosalpingography can help us make sure diverticular extending of the myometrium for the diagnosis. So in our setup, we think it is very important proper way diagnostic tool utilization, and the MUSA classification, the MUSA consensus on the standardization of the classification and reporting of adenomyosis based on transvaginal sonography that include the lesion location, the distinction between focal and diffuse adenomyosis, identification of cystic and non-cystic animal, and involvement of the myometrial layer. At the same time, if you see this picture that in MUSA feature of adenomyosis that is result from modified Delphi procedure. This modified Delphi procedure give us idea about the interrupted junctional zone, irregular junctional zone, asymmetrical myometrial thickening, globular uterus, echogenic subendometrial line and the bulbs, and myometrial cyst that is one of the pathognomic hyperechogenic island, translesional vascularity, and the fan-shaped shadowing. So if we, the gynecologists know about this finding, and in our setup in bedside, if we want to say this sort of the findings, then we can perfectly diagnose the adenomyosis and can formulate the treatment in proper way. And the presence of dilated cystic gland in 50% patient is present in adenomyosis, and it is the myometrial vein. In myometrial vein, we can get the faulty, short circuit, elongated, and tortuosity. It is also very much pathognomic for the diagnosis of the adenomyosis. And the linear striation in the endometrium and subendometrial stripes. This is present in this picture. This is also very much important finding if we want to find adenomyosis in perfect way. If we have the opportunity to do the 4D ultrasound, this is also important to prescribe the patient to do the 4D ultrasound. So in a Cochrane review, it is a big review, and it is showed that MRI is superior than transvaginal sonography. And the combination of the MRI and transvaginal sonography procedure is higher level for the accuracy. In the MRI, we can get widening of the junctional zone, which is normally is 8 millimeter, but in focal adenomyosis, we can get more than 8 millimeter. And in case of diffuse adenomyosis, we can get in 12 millimeter, and there is a presence of a bright foci, which is also for the diagnosis of adenomyosis. We may have a confusion regarding myoma and adenomyoma, but we can give this confusion very much clear by doing the ultrasound in perfect way by saying the shape. In fibroid, it is spherical. Most of the adenomyosis is elliptical, and uterine vascular structure is one of the indication to differentiate between myoma and adenomyoma. In fibroid, it is disrupted, and in adenomyosis, it is intact. So the another thing is hysteroscopy. We can, the fertility specialists, use the hysteroscopy for the diagnosis and the management purpose both together. Because in hysteroscopy, the finding will be visible endometrial defect on uterine septum. After incision, different cystic structure become visible, and incision of the lateral wall, we can reveal the presence of adenomyotic cyst. So by lowering the intrauterine pressure, if we do the surgical procedure, abnormal vascularization and cystic bulging. This is present in this picture. Cystic bulging that is hiding adenomyotic cyst can clearly be identified. So formation of a cyst, still small opening is present, and opening of the defect show the inner side of the cyst is very, very important if we diagnose this by the hysteroscopy, and at the same time, we can do the surgical procedure for the patient. So junctional zone and the junctional zone, that is the important factor because the disruption of the endometrial myometrial interface may lead to adenomyosis and may occur after mechanical damage. So junctional zones important is due to sperm transport, implantation, ectopic pregnancy, recurrent miscarriage, and unexplained infertility. So in patient with infertility, what is doing or what is happening? That is the abnormal uterotubal transport, intrauterine abnormality, uterine peristalsis, destruction of normal myometrial architecture and the function. And there is altered endometrial function and receptivity, aberrant intra-abdominal metabolism, alternation of intra-endometrial steroid metabolism, abnormal inflammatory response, and there is an altered expression of the estrogen and progesterone receptor, altered uterine oxidative stress, And impaired implantation is lack of expression of adhesion molecule, HOXA10, reduced expression of implantation marker, and altered junction gene for embryonic development. These all are worked together, and there is a very, very strong evidence, clinical evidence of positive correlation between adenomyosis and infertility in worldwide, because there is an association of dysfunctional uterine junctional zone and reduce the fertility outcome. Achieving after being treated with GnRH agonist or surgery, negative effect of adenomyosis on reproductive outcome, and compromise ART outcome in patient with adenomyosis association with large miscarriage of the patient. So sometimes it is correlated with adenomyosis and endometriosis in 54 to 90% cases. But however, a large study on baboon that is showed that strong association between histological adenomyosis and lifelong infertility, 20-fold increase in odds, even in case where coexisting is important, where coexisting endometriosis was excluded or not present. In a study of women who received embryo created through oocyte donation, rate of miscarriage were significantly higher in those who had adenomyosis alone versus those with coexisting with endometriosis as a control. And miscarriage rate in women is adenomyosis also higher than in those without adenomyosis. And a recent meta-analysis, it showed that the clinical outcome of IVF in women undergo IVF, rate of implantation, clinical pregnancy per cycle, clinical pregnancy per embryo transfer, ongoing pregnancy, and live birth among women with adenomyosis were significantly lower than in those without adenomyosis. So the treatment option may be medical treatment, surgical treatment, combined surgical and medical treatment, vessel embolization, and high-intensity focused ultrasound. The medical treatment include GnRH agonist, levonorgestrel releasing intrauterine system, danazol, and aromatase inhibitor. But Dinoges is a very good drug nowadays we are using. Recently, a randomized double-blind, multi-center, placebo-controlled trial on Dinoges, and they showed daily administration for 16 weeks in women with adenomyosis showed a significant decrease of pain score in those treated. And the pre-induction treatment, it will help to increase the induction and successful induction rate for those of the patient. The results were confirmed in a long-term treatment study demonstrating good tolerability and reduction in pain and higher quality of the life score. At the same time, the other new drug are selective progesterone receptor modulator, aromatase inhibitor, valproic acid, antiplatelet therapy. In our setup, in our lab, we are using the PRP therapy 48 to 96 hours before the embryo transfer. We are doing the PRP therapy for the patient, and the success rate is quite good for this sort of the patient. And the conservative surgery or fertility sparing surgery is also important for this of the patient. And there are many methods for the conservative surgery, but we can use the trial flap method, laparoscopic cytoreduction surgery, H-incision, or classical adenomyomectomy. But in the operation, it is challenging, especially compared with myomectomy, because adenomyoma are less distinct. During dissection, the plane is identified mainly by the recognizing healthy myometrium. And this can lead to increased risk of intraoperative bleeding and weakening of the myometrium. And the uterine preserving surgery have shown benefit for women who have previously experienced IVF treatment failure, especially if the patient age is less than 40 years. And in retrospective study, conservative surgery for combined surgery with GnRH analog has shown to be more effective in controlling the symptom, and also increase the pregnancy and live birth rate when compared to GnRH analog alone. So surgery and GnRH analog together is a good option for the infertile patient to combat adenomyosis and infertility. For the ART, we can also face the challenges because fair follicle, fewer corpus luteum, M2 site with scattered chromosome, cytoplasmic fragmentation, formation of the pseudopronuclei, spontaneous oocyte activation, reduce the fertilization and abnormal pronuclei, delayed arrested embryo cleavage, and no microtubules in the blastocells are the more challenging part of the ART in adenomyosis. So the big question, when to offer IVF to the patient? Does it affect the IVF outcome? Is medical therapy pre-IVF is useful? Should ICSI always be used? If surgery is needed, which technique? So these are the main thing that we should give answer to the patient and perfect way counseling to the patient, and also for the answer to ourselves also when we're doing this sort of the cases. And there is a comparison is a big data They are showing that the healthy recipient and the severe adenomyosis, there is a problem in the reduction of the implantation, pregnancy, miscarriage, and the live birth rate for this sort of the patient. And also in oocyte donation patient, there is also reduction of implantation, clinical pregnancy, miscarriage, and term pregnancy rate for the adenomyosis of patient. And ART and adenomyosis in large meta-analysis, it is showed that women with adenomyosis undergo ART have a significant lower pregnancy rate compared with women with tubal factor infertility. So during implantation, it is a controversy. Some said implantation is hampered, some said no, the implantation is perfect way. But many evidence, it is suggested that there is a problem of the endometrial receptivity. And the effect of sonographic diffusely enlarged uterus without distinct finding of the adenomyosis, this can also associated with higher spontaneous abortion. So this should keep in our mind also that if sonography diagnoses diffusely enlarged uterus without adenomyosis, this also can hamper for the fertility outcome of the patient. And uterine junctional zone at MRI imaging, a predictor in IVF, junctional zone thickness increase was significantly correlated with the implantation failure. And there is no difference in the primary outcome of the live birth rate in patient with IVF and ICSI treatment outcome. And it is a big data which suggests that adenomyosis reduces the pregnancy rate in infertile women undergo the IVF or ICSI. So is medical therapy pre-IVF is useful? The answer is yes. Because when we are using the GnRH analog, that is reduces the NK cell activity in vitro and which enhance the implantation rate and also enhance the pregnancy rate. So long-term pituitary downregulation before frozen embryo transfer could improve the pregnancy outcome in women with adenomyosis. And we conclude that adenomyosis has a detrimental effect of IVF clinical outcome. But surgery association with GnRH analog or downregulation may increase the level. And the combined surgical and hormonal treatment may be an important factor for the success rate, and laparoscopic excision of the adenomyosis followed by live birth is also a very reassuring procedure for the patient with adenomyosis. Vessel embolization, but it is not widely practiced in the Asian region because uterine artery embolization is an effective and safe method in the treatment of adenomyosis, and it is also infertility treatment part because it is a fertility sparing procedure for the patient with adenomyosis. HIFU, that is very expensive for the Asia Pacific region patient, and it is not available, but HIFU give a combination of coagulation, tissue destruction in a non-invasive bloodless manner under MRI guidance. But for this sort of the patient, the selection criteria should be very specific because patients should 18 or more premenopausal and have no history of PID, and patient is suffering for prolonged infertility or the treatment or failure. For this sort of the patient, we can give an option of the HIFU, but in Bangladesh, it is not available. So when the patient is pregnant, during the pregnancy period, it is also challenging due to miscarriage, preeclampsia, prematurity, placenta previa, stillbirth, or intrauterine growth reduction. So how far we can go, we don't know, because there is a problem of infertility. There is a problem for conception. There is a large chances for the failure for the IVF and ICSI. And when the patient become pregnant with many methods, there is also big chance for the miscarriage and abortion. So with a healthy baby or the live birth rate, how far we can go, we actually, the infertility specialists don't know, because the option of the treatment are limited and the further study are needed to explore the relation of unexplained infertility and adenomyosis, how adenomyosis affect the IVF outcome, diagnostic, non-invasive and reliable tool. And at the same time, adenomyosis is strongly associated with the other gynecological disease that should kept in our mind. Adenomyosis must compromise the intrafollicular development of the oocyte and the alternation of the gene expression, which is also entitled to the uterus. That should also keep in our mind. So there are novel uterus preserving treatment options for adenomyosis that we should utilize. And the definitive conclusion about the efficacy of any of surgical treatment of adenomyosis for subfertility and for implantation failure before IVF are not possible. Limited data support uterine sparing operative treatment of adenomyosis and its variant. Well-designated RCT are urgently needed to answer this sort of the question. The infertility in women with adenomyosis is best treated by hormonal stimulation and IVF, not by insemination. Before you make the diagnosis of unexplained infertility or you have failure of associated conception, please try to exclude there may be the possibility of adenomyosis, particularly in fertile women with heavy period or chronic pelvic pain. So my take-home message is there is still the urgent need for a uniform and shared diagnostic criteria profile and reporting system in both imaging and histology in order to identify all of the clinical and imaging phenotypes of adenomyosis. And that is said by the World Endometriosis Society to all the region gynecologists. And the first step to share a common language among scientists and clinicians who would share the same diagnostic criteria. This would allow clinicians to design and perform methodologically well-conducted prospective study on adenomyosis prevalence, gynecological comorbidity, effectiveness of medical and surgical treatment, and impact on fertility and pregnancy outcome. So more researches are needed for this point of view. So let's work together for the adenomyosis areas. And I am inviting you all from the Endometriosis Adenomyosis Society of Bangladesh in our second International Scientific Conference on March 2024. It will be on 1st and 2nd March 2024. So all of you are invited. And thank you very much, Lashmi Madam, and all of the organizers for giving me this great opportunity. Thank you very much.
Thank you so much, Sharmeen. It was a comprehensive talk which covered from the diagnosis to the management, uterus sparing management, infertility management, and what you included was pregnancy complications. So fantastic talk. I think Dr. Geeta has posted one question. So Geeta, you can ask directly to her.
Yeah, already it was answered in the last.
Okay, so you are
What are
happy.
the complications that may arise once a patient comes with adenomyosis and if she conceives with IVF?
Yes.
Because recently I had a premature delivery around 25 weeks. The baby could not be saved. Survived for a few days. We lost the baby. She came with active labor pains.
Yes, Dr. Sarangi, your comment, then Dr. Behra, your comments as a chairperson. Yeah.
Yes, I want to add Dr. Geeta ma'am's talk. That is, it is very challenging and it is very hurdle for the couple who have adenomyosis to get the pregnancy. They are doing door to door, and it is the state that they are minimum go to 10 to 15 doctor for the final diagnosis and the final treatment approaches. So after that, when they are pregnant, the pregnancy period as a whole is challenging, because the large data, the Cochrane review, PubMed review, and all over the data, all over the country, they are always saying there is a very much challenging part of the early miscarriages. And if the mid-pregnancy, the patient is gone, there is a chances of the PROM, and the preeclampsia has a high incidence, and the low birth weight baby, and the preterm labor. So it's a challenge not for the region specific, it's a problem and challenge of the all over the world together, and they're struggling for doing what we can do here. But the problem is the genetic and epigenetic factor, because this is a genetically determined problem. So it is very tough to do a sort of problem solve. But 1 and 2 study, madam, showed that PRP therapy is giving the pregnancy rate slight prolong. It's a small data, only the 24 pregnancy they are evaluated, and they showed that the patient who got the PRP therapy and who are not getting the PRP therapy getting patient can continue the pregnancy up to 32 and 33 weeks. So this can be an option that we can think in our mind.
How frequently you give PRP therapy? During pregnancy, do you give?
No, madam, before the pregnancy, in IVF pregnancy, embryo transfer 48 to 96 hours before the embryo transfer.
Sharmeen, there is one more question from Dr. Neena Singh. Role of ormeloxifene in adenomyosis.
It have a good role, but in some country it is restricted to use because they have a lack of the data. So if we want to routinely use it, we need to do more researches on it, and after that we can prescribe it in routine way for the management of adenomyosis.
Yes. Dr. Sarangi?
Well, thank you, ma'am. Actually, you have made us more fearful about this enigmatic disease. Yes, right diagnosis is very difficult in this, as well as right therapy and outcome you have already said. I've got a simple question. Is there any role of cabergoline in this? Hello.
It's a very nice question, sir. And we have a research on it in our Bangabandhu Sheikh Mujib Medical University, the largest university in our setup in Bangladesh. And in reproductive endocrinology department, we are doing researches on it. And the preliminary research finding I can share with you with the permission of the chair. That is,
Please.
when we are using cabergoline, there is a neuroagenesis process is called. That is the data, that is the pathogenesis pathway is said. And the patient where we are uses the cabergoline, and we are using the cabergoline, the dose is 1 cabergoline in every 3rd day. In our research on our university setup, we are using it and we are continuing it for up to 2 or 3 months. And after that, we are doing the transvaginal sonography in our setup. And we get the positive result. Those patients, we are using the cabergoline. And we have another study where we are using dianogus and cabergoline together. And when we're using dianogus and cabergoline together, we are getting more good result than the patient who are alone using the cabergoline. So this can be the option, but the large data we are needed. In our setup, we are doing the researches on this too. And after 6 months, I think we can publish it and we can share with you people.
0.25 milligram or 0.5 milligram?
0.5, sir.
0.5.
Yeah.
Well,
In
thank you
case of
very much, ma'am.
infertility, do you give cabergoline and dinogest for a while and then attempt
Yes,
IVF?
for the pregnancy.
How
Yes,
long
then
you give?
attempt for natural pregnancy or then for the IVF. But the treatment period is not more than 3 months for this sort of the patient, because there is a contaminated presence of the endometriosis of many of the patient. And we need to think about the age of the patient and also the ovarian reserve of the patient. All this together, we can judge and we can take the decision about the patient. Those patients who have a low AMH level, at that patient, we cannot wait more time with doing the medical treatment for this of the patient. And this sort of the patient, we can thinking about giving the GnRH analog for 3 months, then go for the ART directly. And for the mild adenomyosis patient or those patients who have a good AMH, those patients who are young, those patients who have a short period of infertility, for this sort of patient, as a pre-treatment of ART, we are using cabergoline and dinogest together.
One
Okay,
question,
thank you,
ma'am.
ma'am.
Can I ask one question, Lakshmi madam?
Yes, please.
What about letrozole, Shami madam? Letrozole.
Yes, letrozole is a good option, madam. Letrozole is using for the induction purpose, but as a treatment purpose, letrozole, calcium, and norethistérine together also have a good effect for the adenomyosis patient. We have a data on 32 patients, and where we are using letrozole to the patient, we are using norethistérine to the patient and also calcium in combination. And it is showed that it will decrease in mild adenomyosis in a good level. But for the severe adenomyosis patient, madam, the result is not very much satisfactory. So for the short period, the AMH level is good, ovarian reserve good, patient is young, we can make an option for this sort of the treatment.
Dr. Behra, your comments? Yeah, before we move on. Yeah.
Madam has very nicely elaborated all things from pre-pregnancy, during pregnancy, during IVF, what are the problems, and during pregnancy, what are the complications of adenomyosis. So I have nothing to ask. Thank you, madam.
Sharmeen, our heartfelt gratitude on behalf of ISOPA for accepting the invitation and logging from Toronto at 7 a.m. and giving such crystal clear take-home messages to all the audience who have logged in, and many people have logged in on live YouTube is also going on. So I am so happy to have you here on this platform, and there was so much interaction on your talk, because the adenomyosis is really challenging. So we really struggle when patient comes to us, but now after your talk, I'm sure the audience will find it much easier to tackle the adenomyosis, especially if they come to us with infertility. So thank you so much, Sharmeen, for being with us.
Thank you, madam. My love and respect always for you and also for the team, madam. Thank you very much.
Thank you, Sharmeen. So, yeah, so Priya, let's move on to second. Yeah.
So with this, we are over with the first session and we come to the second session now. The topic for this is the latest guidelines of ESHRE on endometriosis and infertility. The speaker is none other than the convener of this program, Dr. Lakshmi Srikhande Madam. And to chair the session, we have Dr. Chandra Mansukhani. She is the gynae endoscopic and robotic surgery in adolescent health. Her designation is she's a senior consultant in charge of adolescent clinic at Sir Gangaram Hospital. She'd been the treasurer of NARCHI Delhi and IMS Delhi chapter, joint secretary AOGD in 2008 and 9, secretary NARCHI Delhi chapter and vice president ISOPAP Delhi chapter, vice president IMS Delhi chapter, and she'd been also the editor of AOGD 2021, president ISOPAP Delhi chapter till date, from 21 till date. So welcome, madam. And the next chairperson is Dr. K. Geeta Devi. She is graduated from Guntur Medical College and post-graduation from Kasturba Medical College, Manipal. Worked as assistant professor at SRMC, Chennai. Then she is now working as senior consultant at Ayush Hospital, Vijayawada, which is a multi-specialty hospital, and has vast experience in dealing with high-risk and critical care of obstetrics. Her area of interest are high-risk obstetrics and endoscopy. She is the president of ISOPAP Vijayawada branch and member of Indian Menopause Society. So welcome you, madam, and I request the chairpersons to introduce the speaker.
So good evening, everyone. Dr. Geeta, can I introduce our
Yes,
speaker?
ma'am. Yes, ma'am. Yes, yes.
Yes.
Yeah, so good evening, everyone. And first of all, I would like to thank Dr. Lakshmi Srikhande and Dr. Supriya for making me part of this important talk, webinar, and where there was an international speaker, and really I learned so many important points from her lecture. So here I'm going to invite Dr. Srikhande to speak on latest guidelines of ASHRI on endometriosis fertility. Dr. Lakshmi Srikhande does not need any introduction. She's a well-known dignitary all over the India, and Dr. Lakshmi is a fertility specialist, laparoscopic surgeon, and no scar hysterectomy specialist also. Her focus is on delivering the compassionate, custom-made, highest quality treatment to individuals according to their needs while incorporating the latest development in fertility. She is instrumental in bringing happiness to the lives of thousands of childless couples nationally and internationally. So, Dr. Srikhande, now it's over to you to speak on a very important topic.
Yes. Thank you. Thank you so much, Dr. Chandra, for your generous introduction. And friends, after Sharmi's talk on adenomyosis, now I am presenting with the latest ISHRE guidelines as far as endometriosis and infertility is concerned. And we are so happy that we have latest guidelines on endometriosis, which makes our life easier. So just to introduce the subject, we all know endometriosis is a very common debilitating disease that occurs in 6 to 10% of the general female population, and in women who comes to us with pain, subfertility, or both, the frequency is 30 to 35%. About 25 to 50% of subfertile women, they have endometriosis, and 30 to 50% of women with endometriosis are subfertile. We don't use the word infertility, we use the word subfertility because it is a word that gives them hope. Infertility is a very crude term. So what are the possible causes of subfertility in those women who have endometriosis? It can be because of adhesions, chronic intraperitoneal inflammation, disturbed folliculogenesis, luteinized unruptured follicle, luteal phase defects, progesterone resistance, detrimental effect on spermatozoa, anti-endometrial antibodies, and dysfunctional uterotubal motility. Before I start the treatment option, everyone should be familiar with the revised ASRM grading of the endometriosis. Grade 1, minimal endometriosis. Grade 2 is mild. Grade 3, moderate endometriosis. And grade 4 is severe endometriosis. So ISHRE in its 2022 guidelines have a dedicated section on the treatment of endometriosis associated infertility, where they have answered all our questions. Usually we have questions whether we can give medical therapies for endometriosis associated fertility, whether surgery will be effective, whether it will increase the chances of natural pregnancy, which patients need treatment with ART, and are medical therapies effective as an adjunct to the minimal invasive robotic surgery for endometriosis associated infertility. So I will be answering all these questions step by step during my presentation. So let us try to answer the first question. Are hormone/medical therapies effective for treatment of endometriosis associated infertility? This question has been thoroughly evaluated in a systematic Cochrane review, but this review does not evaluate the individual hormonal treatment. So strictly speaking, the assessment is confined to the role of ovarian suppression as a therapeutic modality to improve fertility. So in the analysis, evaluating the effect on clinical pregnancy rate after the use of any ovulation suppression agent versus placebo or no treatment, in this study, 12 trials were included, and from this trial, it was clear that as a sole treatment for endometriosis associated infertility, you are not supposed to prescribe these drugs. So this is the summary of the answer to this question, that in subfertile women with endometriosis, clinicians should not prescribe ovarian suppression treatment to improve fertility. And this is the justification that based on the Cochrane review, suppression of ovarian function by means of danazol, GnRH agonist, progesterone, or even OC pills to improve fertility in these women is not effective and should not be offered for this indication alone. Now, the second question was whether you can give hormone or medical therapy as an adjunct to surgical therapy. So again, there was a Cochrane review where 25 trials were included and 3,378 women with endometriosis were included in this trial. The difference in pregnancy rate between post-surgical and pre-surgical medical hormone suppression therapy in this review was found to be uncertain. So the guidelines are telling us that women who are seeking pregnancy should not be prescribed post-operative hormone suppression with the sole purpose to enhance future pregnancy rates. Those women who cannot attempt to, or they cannot decide not to conceive immediately after surgery, only these two classes of women may be offered hormone therapy, as it does not negatively impact their fertility and improves the immediate outcome of surgery for pain. Now, is there any role of anti-inflammatory drugs in the management of endometriosis? We all know that endometriosis is associated with inflammation. So anti-inflammatory drugs are potentially of interest to be evaluated as an alternative approach. There was a Cochrane systematic review on this issue published in 2021. The guidelines are telling us that in women who are having endometriosis and subfertility, clinicians should not prescribe pentoxifylline or any other anti-inflammatory drugs or letrozole outside ovulation induction to improve the natural pregnancy rates. Now we have answered the questions related to the medical therapies. Now let us come to the surgical treatment. When we are talking of surgical treatment, we will be discussing it in peritoneal endometriosis, endometrioma, and deep endometriosis. So this was the question as far as peritoneal endometriosis, whether surgery is effective to increase the chance of natural pregnancy in cases of peritoneal endometriosis. Again, this is the latest Cochrane review published in 2020, and based on the moderate quality evidence from 3 RCTs, mainly on peritoneal endometriosis, the review concluded that laparoscopic surgery increases viable intrauterine pregnancy rates, which are confirmed by ultrasound, compared to a diagnostic laparoscopy only. A similar conclusion was formulated from a recent network meta-analysis by another author. Now coming to the ovarian endometriosis. There is also a trial, and the authors of this trial, when they compared fertility outcomes after surgery for endometrioma in comparison with expectant management, they did not find any RCTs in the literature to have this comparison. However, we do have a review by Alborzi et al. Based on the combined results of 8 studies. This author has shown that there is no significant difference when from other treatments such as surgery combined with ART only, or aspiration plus sclerotherapy plus ART. We all know that if there is an endometrioma, there are mainly 2 types of procedures, cystectomy or ablation of the inner surface of the cyst wall in situ. It should be noted that none of the studies discussed were stratified according to the endometriosis fertility index, which I have mentioned above the studies. Now let us come to the deep endometriosis. Although there is no compelling evidence exists that operative laparoscopy for DE improves fertility, operative laparoscopy may represent a treatment option in symptomatic patients who wish to conceive. So the GDG recommends that the decision to perform surgery should be guided by the presence or absence of pain symptoms, patient's age and preferences, history of previous surgery, presence of other subfertility factors, ovarian reserve, and estimated EFI. Which patient should be offered ART after the surgery? So before and after surgery of endometriosis, those women who wish to become pregnant, they should be counseled objectively on their subsequent chances of achieving a pregnancy. To this purpose, EFI was developed by Adamson and Pasta way back in 2010, and this has been shown that the end of surgery, EFI can be estimated accurately prior to surgery. This estimation could be used as an instrument to guide joint physician-patient decision-making between surgery, ART, or other fertility management options for the individualized treatment of women with endometriosis-related subfertility. So what is this EFI? This is the Endometriosis Fertility Index form. You all can download these from the Google. So these guidelines have summarized the answer to this question, that is, who needs ART after surgery? Women, they should be counseled. To identify patients that may benefit from ART after surgery, the EFI should be used as it is validated, reproducible, and cost effective. The results of other fertility investigations, such as their partner's semen analysis, should be taken into account. There are very few studies which has assessed the efficacy of IUI with or without ovarian stimulation in women with endometriosis. So in subfertility women with revised ASRM stage 1 or 2 endometriosis, clinicians may perform IUI with ovarian stimulation instead of expectant management or IUI alone, as it increases the pregnancy rates. Although the value of IUI in revised ASRM stage 3 or 4 endometriosis with uncertain tubal patency, the use of IUI with ovarian stimulation could be considered. To our knowledge, there are currently no randomized trials evaluating the efficacy of ART versus no intervention in women with endometriosis. Indirect evidence can be derived from studies comparing the outcomes of ART in women with endometriosis to women without endometriosis. In a more recent retrospective single center cohort study, which comparing 531 patients with endometriosis to 737 with unexplained infertility, the authors found out that women with endometriosis, they had fewer oocytes which were retrieved, there was lower blastocyst transfer and a significantly reduced implantation rate. So the impact of endometrioma on ART reproductive outcome was summarized in this another recent review article, and they also showed that the number of oocytes and the number of M2 oocytes retrieved were significantly lower in those women who were having endometriosis. Now, if you are offering ART, which protocol you should use, whether it should be a GnRH agonist protocol or GnRH antagonist protocol. So to answer this question, there was a recent randomized control trial which included 246 women with stage 1, 2 endometriosis and endometrioma, and they showed that the implantation rate and clinical pregnancy rate after ovulation stimulation in a GnRH antagonist cycle were not inferior. Mind you, the word used is not inferior to those for a GnRH agonist protocol. So which protocol to be used? ART, you can use either agonist or antagonist. ART can be performed for subfertility associated with endometriosis, especially if tubal function is compromised, if there is a male factor present, in case of low EFI, or if other treatments have failed. A specific protocol for ART in women with endometriosis cannot be recommended. Both GnRH antagonist and agonist protocol can be offered based on patients' and physicians' preferences, as no difference in pregnancy or live birth rate has been demonstrated. Women with endometriosis can be reassured regarding the safety of ART since the recurrence rates are not increased compared to those women who are not undergoing ART. Especially, we are always concerned about the endometrioma, the abscess formation. So in women who are having endometrioma, clinicians may use antibiotic prophylaxis at the time of ovum pickup, although the risk of ovarian abscess formation following follicular aspiration is low. So you have to follow all the aseptic precautions, and top of that, you can give antibiotic prophylaxis. Can you use medical therapies? Are they effective as an adjunct to your surgery for endometriosis associated infertility? It has been proposed following numerous non-randomized studies that medical treatment of endometriosis prior to ART may result in improved outcome either because of improving oocytes quality or endometrial receptivity. The specific question of GnRH agonist pre-treatment, there was an old systematic review, and now there is an updated version of this Cochrane review which was published in 2019, which included 8 parallel design RCTs with 640 participants. They concluded that the effect of GnRH agonist pre-treatment for at least 3 months was very uncertain, both on the live birth rate as primary outcome as well as on the secondary outcomes. A more recent RCT investigating the effect of ultra-long administration of GnRH agonist failed to demonstrate a beneficial effect on implantation rate, clinical pregnancy rate, or embryo quality. Pre-treatment with continuous OCPs for 6 to 8 weeks as compared to no pre-treatment before ART indirectly suggested a potential beneficial effect on clinical pregnancy rate, and there are no studies comparing the effect of different medical therapies for pre-treatment prior to ART. So what is the summary of this question? The extended administration of GnRH agonist prior to ART treatment to improve live birth rate in subfertile women with endometriosis is not recommended as the benefit is uncertain. There is insufficient evidence to recommend prolonged administration of the COC pills or progestogens as a pre-treatment to ART to increase the live birth rates. Now we are coming to the surgical treatment of endometriosis prior to ART. So in a review and meta-analysis of Hamden, 12 studies were included which evaluated ART outcomes after surgery to endometriosis. And this review reported no difference in live birth rates, CPR, or mean number of oocytes retrieved compared to women without endometriosis. So clinicians are not recommended to routinely perform surgery prior to ART to improve the live birth rates in women with revised ASRM stage 1-2 endometriosis, as the potential benefits are unclear. Two systematic reviews and meta-analysis have evaluated the impact of endometrioma surgery on ART outcomes and surgical treatment. We all know they do cause reduced antral follicular count. They do cause increase the requirement of the gonadotropin injection dose for ovarian stimulation. And the second recent systematic review and meta-analysis, they failed to demonstrate a significant beneficial effect of surgery on live birth rate. So clinicians are not recommended to routinely perform surgery for ovarian endometrioma prior to ART to improve live birth rates, as the current evidence shows no benefit and surgery is likely to have a negative impact on the ovarian reserve. Surgery for endometrioma prior to ART can be considered to improve endometriosis associated pain or the accessibility of follicles. So these are only two indications where you have to consider surgery prior to the ART. What is the role of surgery in deep endometriosis? The decision to offer surgical excision of deep endometriosis lesions prior to ART should be guided mainly by pain symptoms and patient preferences, as its effectiveness on reproductive outcome is uncertain due to lack of randomized trials. Is there any role of non-medical therapies? There was a systematic literature review looking at the Chinese medicine post-surgery, but they were only able to include 2 studies, and what they found out. They did not find any improvement in pregnancy rates with the use of Chinese medicines. Compared to that, vitamin C and E with placebo and measured oxidative stress markers are believed to be linked to fertility. However, there was no increase in the pregnancy rate. So as far as non-medical strategies are concerned, there is no clear evidence that these therapies will be of benefit to increase the chances of pregnancy in these women of endometriosis. Now, what is the role of fertility preservation? Patients with severe endometriosis, particularly bilateral endometriomas, they are at higher risk of premature ovarian insufficiency and lower AMH levels. And surgical treatment can further have a negative impact on their ovarian reserve and AMH levels. So in case of extensive ovarian endometriosis, clinicians should discuss the pros and cons of fertility preservation with women, and the true benefit of fertility preservation remains unknown. Now, I am so happy that Sharmin also highlighted the impact of adenomyosis on pregnancy and pregnancy outcome. And here I am highlighting, rather these guidelines have highlighted the impact of endometriosis on pregnancy and pregnancy outcome. I don't know how many of you tell your patients that pregnancy will cure endometriosis. Let us have a look at this slide very, very carefully, what the guidelines have to say on this issue. It is not uncommon for women with endometriosis to be advised that becoming pregnant might be a useful strategy to manage symptoms and reduce disease progression, as pseudo-pregnancy induced through hormone therapies, they have a positive effect on symptoms. But remember, not all endometriotic lesions, they seem to deciderialize during pregnancy, as some might undergo atrophy, fibrosis, and necrosis. Pregnancy does not seem to systematically result in benefits for women with endometriosis, and women should not be advised to discontinue periodic evaluations and or medical treatment after delivery. So they should not be advised to become pregnant with the sole purpose of treating endometriosis, as pregnancy does not always lead to improvement of symptoms or reduction of disease progression. Endometriomas may change in appearance during pregnancy, and in case of finding an atypical endometrioma during ultrasound in pregnancy, it is recommended to refer this patient to a center with appropriate expertise. Complications deriving from ovarian endometriotic cysts such as infected, enlarged, and ruptured endometrioma represent rare events, but they should be considered in the differential diagnosis of pelvic pain during pregnancy. So as an obstetrician, you all should know what problems can occur during pregnancy. So you have to keep in mind if she had endometriosis before she became pregnant. What can be the gastrointestinal side effects? Spontaneous intestinal perforation is a serious complication. I know it's rare, requiring urgent surgical treatment, and it has been hypothesized that extensive decedulization might weaken the bowel wall or that adhesions might cause traumas during uterine growth. As far as urinary system is concerned, the urohemoperitoneum is very rare. So far in the literature, only 2 cases have been reported. Spontaneous uterine rupture is also very rare, and it has been described in 3 cases only, all with a history of endometriosis surgery. Although the etiology of spontaneous hemoperitoneum in pregnancy is still mysterious, its occurrence seems to be increased in endometriosis. The bleeding arises from pelvic endometriotic implants or ruptured vessels, which are most often situated on the posterior uterine surface or in the parametrium, and this occurs mostly in the 3rd trimester of pregnancy. So as far as complications are concerned, complications related directly to pre-existing endometriotic lesions are rare, but probably underreported. Such complications may be related to their decedulization, adhesion formation, stretching, and endometriosis-related chronic inflammation. Although rare, they may represent life-threatening situations that may require surgical management. So what is the impact of endometriosis in 1st trimester? The data on miscarriage rate in women with endometriosis versus control is somewhat conflicting, although most studies and systematic reviews have observed an increased risk of miscarriage in endometriosis. There were insufficient data to make any conclusion as far as the risk of ectopic pregnancy is concerned in cases of endometriosis, but the clinician should be aware that there may be an increased risk of 1st trimester miscarriage and ectopic pregnancy in women with endometriosis. What about the impact of endometriosis on 2nd and 3rd trimester? There have been many studies in the literature showing an association between endometriosis and adverse outcomes of pregnancy in terms of maternal, fetal, and neonatal that are summarized below. That in a systematic review and meta-analysis of 33 studies, they reported higher odds of gestational diabetes in these women. Fetuses and neonates of women with endometriosis, they were more likely to have premature rupture of membranes as well as preterm birth. Compared to those women without endometriosis, a higher incidence of placenta previa has been reported in these cases of women, and a possible explanation might be the abnormal frequency and amplitude of uterine contractions observed in these women, leading to anomalous blastocyst implantation. In a systematic review of 13 studies, including almost 40,000 pregnancies with endometriosis diagnosed by biopsy and 283,000 diagnosed without endometriosis, these authors did not find any significant difference in the incidence of preeclampsia, eclampsia, and HELLP syndrome, nor they did find any difference in pregnancies achieved spontaneously or by ART. What about stillbirth? Women with endometriosis, they were more likely to have experienced stillbirth. What about the cesarean section rate? They are found to be higher in those women who are having endometriosis. What about the risk of obstetric hemorrhage? This systemic review did not observe an increased incidence of placental abruption or APH in these women versus control. However, the risk of placental abruption in another meta-analysis, it was found to be increased in women who had endometriosis. With regards to postpartum hemorrhage, the risk is not increased in those women who are having endometriosis. What about the fetal outcome as far as the risk for small for gestational age, requirement for admission to NICU or neonatal death is concerned? Remember, these women are more likely to have babies who are small for gestational age. For IUGR, they are more prone for adverse neonatal outcomes as well. Clinicians should be aware of endometriosis associated complications in pregnancy. Again, although these complications are rare, we should be aware as these findings are based on low or moderate quality studies. These results should be interpreted with caution, and currently they do not warrant increased antenatal monitoring or to dissuade women from becoming pregnant. So friends, I am sure I have tried to answer all these common questions related to management of endometriosis in fertility, that is role of medical management, role of surgical management, whether there is any role of surgery prior to ART, which stimulation protocol should be used, and what is the effect of endometriosis once this woman becomes pregnant during first trimester, during second trimester, and during third trimester. But remember, as Dr. Sharmin, Dr. Pragya, everyone is saying that we cannot follow guidelines word by word in our clinical practice. They are there for the guidance. You should try to follow these guidelines as far as possible where it is feasible, but individualization is the key for managing these cases. And of course, you all should utilize the EFI index when you are managing these cases of endometriosis who come to you for subfertility. So thank you, friends. Thank you so much for your patient hearing. Sharmila, if you are happy, you can comment if I have missed something.
It's a lucid presentation and very crystal clear messages you have given, ma'am. And starting with the questions that are commonly asked with endometriosis and infertility. And you have explained each question in detail with quoting some studies and when to go for ART and EFI, how to use it, and which is better, or both are same, GnRH analogs or antagonists. Very well said, ma'am.
Sharmin, your comments, you can unmute.
Excellent presentation, madam. You are just evidence-based presentation, and your talk was according to our need and our approaches, what is feasible for us actually, because Eshe gave us many more things, but feasibility and accessibility is also important. Your talk is according to our need and how we can afford, madam. It's a super and excellent presentation, madam. Your talk is always very much enriched and evidence-based. We always bless to when we get a presentation from you. So it's a very nice presentation, madam. Thank you very much.
Thank you, Sharmin. Thank you.
Thank you, Dr. Lakshmi Shrikande. It was a wonderful lecture and you cleared each and everything, talk about all the questions. But I want to ask two questions. One, for how long you would like to give the clomiphene in endometriosis, and for up to what size you would not like to operate the patient of the endometrioma?
I would like to pass on this question to Sharmin before I share my experience. Clomiphene, Sharmin, I know she is an expert. Yeah.
In case of surgery, if we want to take regarding the decision of the surgery, that when we go for the surgery, the consensus result and the recommendation from the World Endometriosis Society and Asian Society of Endometriosis, they are always talking about rethink before doing surgery, because nowadays only one thing, that the size of the endometrioma is not the predicting factor or not only the indication. We need to evaluate the profile of the patient, age of the patient, ovarian reserve, the fertility history, if any previous pregnancy or not, and with the size. There is a no cutoff value, because Eshe gave us the idea that 4 centimeter cyst and we can go for the surgery. But in some sort of the infertile patient, 8 centimeter, 10 centimeter cyst can approach us with the medical management, and after that successful pregnancy is an evidence. So the guideline from the West and the Asian Society of Endometriosis, they are talking about please rethink before doing any surgery, please rethink about the profile of the patient, and after that we can take the decision for the patient. No cutoff value or no individual, only the diameter of the size of the cyst is not the indication.
Yeah, previously it was 6 centimeter used to be the cutoff, but no more. As you said, we have to look for the other patient profile before we even decide to offer her a laparoscopy, because laparoscopy per se has got many side effects. As far as recurrence chances are there, it will definitely decrease her ovarian reserve. So when we have to plan surgery, we have to really think about the pros and cons, whether it will be really beneficial for this particular patient who has come to you. So,
But suppose
Exactly,
she's
madam.
priming, Dr. Lakshmi and Dr. Sharmin, she's a primee and she has been trying since last 1 year, suppose, and age is 33, 34 years. She has not conceived, and ultrasound shows the 10 centimeter endometrioma. So what should be the line of management? Whether we should offer her surgery or we still give her medical treatment, or directly we start the induction ovulation? What should be the management?
For this sort of patient, actually, madam, with permission of Lakshmi, madam, I want to add that for this sort of the patient, the ovarian reserve result is very, very important, madam. If the ovarian reserve is good for this sort of patient, we can go directly for the surgery, because surgery is a 10 centimeter cyst. It will enhance the fertility in future. But if the ovarian reserve is poor, at that time, madam, ovulation induction, then we can take the ovum pickup, then we can preserve that, and after that we can go for the surgery. It will be a good option for this sort of the patient if the ovarian reserve is low. But 10 centimeter cyst with the symptoms of the patient, because we need to judge the symptom of the patient. Symptomatic
Sorry,
or
Dr.
asymptomatic,
Sharmin, if
madam?
she's asymptomatic, just ultrasound has shown the 10 centimeter endometrioma. She's trying for the pregnancy. That is the only symptom, and no pain, nothing, and regular cycles. So directly can be given an induction of ovulation, or we can tell her for the natural conception. She has been trying since last 1 year and she has not conceived yet.
If madam, the ovarian reserve is good, AMH level is 2 or more than 2, or minimum within the range of 1.5, at that patient, at that point of view, we can give a suppression therapy, and after that induction may be a choice if the patient is response with the GnRH, Dinoges, or combination of the other 4 drugs, suppression therapy. But if the patient is not responsive, at that moment, surgery is the second option for this sort of patient.
Especially Dr. Chandra, if there are other coexisting factors, like you want to evaluate the tubal factors, or you are suspecting any other peritoneal factor, then you are justified in offering laparoscopy. Otherwise, as Sharmin has said, now size alone is not a criteria. I know in Indian settings, they go to so many gynecologists and looking at the size. Even I have seen patients coming to me who have been offered laparoscopy just for the 2 centimeter cyst and 3 centimeter cyst. So I'm sure 10 centimeter cyst.
That is not
she has been advised laparoscopy, but we have to talk in terms of the guidelines. And many patients, they really understand when we tell them that this is the evidence, and let them choose. You tell them the pros and cons. But Sharmin is very clear, because she's 30 plus. And we all know that Indian women, they age 6 years earlier as compared to Caucasian women. So we have to do the AMH, the age of the patient, and antral follicular count. So these factors taken into account, you will take a call. And again, we are emphasizing that individualization is the key for giving them the optimum outcome as far as fertility is concerned. So we just can't follow guidelines to the dot.
So thank you, madam.
I encountered one more patient. Sorry, I'm asking one more question.
Arup sir has got some commitment, and sir has joined actually. He has got some commitment.
We will discuss. We have our president of National ISOPA, Dr. Arup Kumar Maji, who has logged in. Sir, sincere gratitude for logging in, and I request Supriya to introduce you so that we can have pearls of wisdom from your side.
So good evening and welcome, sir. Professor Arup Kumar Maji, sir, he is President ISOPAB, he is Professor Santiniketan Medical College, Bolpur, West Bengal. He's author of so many books, former professor and head of OBGY RG Medical College, Kolkata, President Bengal OBGY Society in 2016-17. Sir had been the president of Kolkata chapter of ISOPAB in 1820. Then 2018 and 20, Scientific Committee co-chairperson in AICOG 2023 at Kolkata. That was a real hit program of AICOG, one of the best one. 30 years of teaching experience and examiner of UG, PG and DNB of various universities. Sir has got more than 100 publications in national and international journal. He is editor, Indian Journal of Perinatology and Reproductive Biology, past national corresponding editor of Jogi. Sir is teacher of teachers and a great human being. Sir, welcome you, and over to you for your pulse of wisdom, sir.
Thank you, Dr. Supriya, for your kind and nice introduction. I actually very sorry for my late joining, and due to the other assignment also, I could not control myself, check myself when Dr. Lakshmi Sikandre does something. And most of the deliberations I have heard are very, very beautiful and extensive. And one thing is that her Seed to Bloom series, this is the 4th series, I think. It is the 3rd series was held on 21st July, probably. And the Fertility Enhancing Committee, the two very, very dynamic conveners are Dr. Lakshmi Sikandre and Dr. Supriya Jaiswal. And I am very nice to see the New Delhi, Burla Sambalpur, Lucknow, Vijayawada, and Kanpur city chapters, all stalwarts are involved in this program. And the first program has actually definitely missed. That was a very definitely was good. That Sarvin Abbasi. So welcome, Dr. Sarvin Abbasi, for this beautiful program I have missed. And your topic was adenomyosis. That is a very difficult topic, but I have strong interest on those two topics. And the latest guideline of the SD, Dr. Lakshmi Sikandre has beautifully presented, I have told you, because the important thing is she has said that guideline definitely will have to follow, but for individual patient, we cannot follow strictly all the guidelines. But one thing we'll have to, she has also told that we'll have to counsel the person regarding what will be the prognosis, this is the option, and he'll have to give the option, because endometriosis is a disease of unpredictability in all aspects. That symptoms, the progress and infertility, all the things. And another important panel is waiting. It is by the Dr. Sampath Kumari. The Vice President is a very good friend of me. So I will not now stand between Dr. Sampath and her stalwart teams of Mala Srivastava, Uma Sinha, Nilam Mishra, and Kiran Sinha and Lata. So please, you will start. We are already delayed. With the best wishes for the grand success of the CME. And please, Dr. Lakshmi and Dr. Supriya, please continue wait for the 5th series. Thank you all. Thank you. I will try to hear Dr. Sampath Kumari's teams and what they tell. Thank you. Thank you all.
Thank you so much, sir, for sparing your time and logging in. And we will definitely continue this Seed to Bloom series. Thank you. Shamin, before you log out, can you just answer what somebody has asked, the role of TAP and the role of aspiration?
No, madam, I am with you with the full program, no problem.
So what is the role of TAP and aspiration?
Aspiration is a good choice. Aspiration is a good choice, but there is a chances of the recurrence is more. But when the ovarian reserve is low, so aspiration is one of the option. But it is better because the first surgery should be the best decision surgery. First surgery should be the best surgery. First surgery should be the best handed surgery. And the patient selection for the first surgery should be the best decided surgery. So for all this sort of decision when made, then cystectomy is the best approaches, because there is a less chance for the recurrence of the endometrioma again. So if we can do the judicial cystectomy, if we can use the judicial coagulation procedure, and if we can use the judicial coagulation technique for this sort of the patient, this will be the best method for the patient to reduce the recurrent state and also to maintain the fertility. But there is a one thing that is after every surgery or after every coagulation, there is a loss of the ovarian tissue. That is inevitable and it should kept in our mind. So this should be properly counseling with the patient, because after the surgery, many patients by herself do the AMH level or ovarian reserve, and there is a decline when they can give an option to the doctor where it is declined. So before doing any surgery of endometriosis surgery, proper counseling and with all the pros and cons is very important to inform all the patients.
Chairman, what is your take on preoperative AMH and postoperative AMH in these cases? Whether we should do AMH pre-op and post-op routinely before offering them surgery?
Yes, offering the surgery, madam, I have a study of a 70 patient, and where we are saying that if the patient age is below 40 years of age, and after doing the surgery, there is a variation of the 0.5 to 1.
Yes.
Of the AMH level, preoperative and postoperative, and the age is more than 40, at that level, the detrimental effect is more than the below 40 age patients. So this is also a, I think, determinants of taking decision that the patient with a more age, we go for surgery or not, because let's cyst and go for surgery is not the only one decision nowadays.
But in Indian setting, even to share my practical experience, I am doing pre-op AMH and post-op AMH, which makes my life easier, because if pre-op AMH is only low, as Sharmin is telling again and again, then your treatment modality and your approach to that patient becomes entirely different. And even if AMH is good, you have to counsel that post-operative, your AMH level is going to decline, because whatever you are doing, whichever surgery you are doing, so we have to counsel them. And AMH really comes handy to tell them ki baba preoperatively it was low or whatever. So in clinical practice, we are doing the AMH levels.
But madam, I have a finding in our research that I don't know, do you agree it or not? After the surgery, within 1 month, the AMH level is
We don't do.
And
yeah.
After 3 months, it will
Yes.
increase than the 1 month result. So there is
yeah.
also a variation.
Great.
So if a physician will do the AMH level just after the operation or after, within 1 month, I think the result can be a trouble for the patient and also for the fertility specialist also.
Yes, very good point, Sharmin, that post-operative, if we are planning to do AMH, please do after 3 months of the surgery, to give you a fair idea about the ovarian reserve.
Dr. Lakshmi, one thing is, what is your experience about the use of cabergoline and
She shared, Sharmin will answer again because he is logged in now. Cabergoline. Sharmin has already answered. Sharmin, please will you answer it again?
Orup sir, we have experience of a patient in our university, Medical College University of Bangladesh. We are using cabergoline of a group of the research patient. It is not published yet, but there is some assumption data that cabergoline is working to the endometriosis patient. And we are using cabergoline. It is a halt the process of the angiogenesis, neuroangiogenesis. This process too are halt by the giving the cabergoline. And also when we combine with Dianoges and cabergoline, the results is more good than alone cabergoline. So this can be an option using the patient. But I think from my point of view and personal experience, I am prefer to use Dianoges and cabergoline, a combination recipe. So it's good for the patient.
During the introduction of the continuation of the cabergoline, we can allow the patient for pregnancy. That is the advantage of cabergoline.
Actually, they are using for the endometriosis and adenomyosis patient like a suppression, sir. So for the suppression, we can use it. But if the patient is pregnant, if anyone want to continue it, we may continue it, sir. It's not an absolute contraindication for using it, but for the patient, actually, we are using it for the suppression, and after that, we can go for the induction, sir.
Thank you. Thank you.
Thank you, Sharmi. Thank you, sir. Adi sir. Supriya, let's go for our last session here.
Yeah. So thank you very much. We have the second session has come to an end, and we start with the panel discussion now. The moderator is none other than Dr. S. Sampath Kumari, Madam, who is the Vice President of Oxy at present. Madam is Founder Secretary TNFOG, National Corresponding Editor Jogi 21 to 24, Senate Member of TNDR MGR University, Chairperson Foxy Adolescent Health Committee.
Supriya, you can proceed, Supriya.
Yes, Madam is she is editor of many textbooks, Foxy Focus and newsletters. I welcome you, Madam, to moderate the session. And then we have learned panelist, Dr. Mala Srivastava. She is from Delhi. Madam is awardee of Foxy Achiever Award, and she has got lots and lots of accolades. Then she is also the president of ISOPAP Delhi chapter. And Madam, she is joint secretary of many things, many organizations. She is a fellow of minimal access surgery, trained in robotic surgeries at France. So, Madam, I welcome you. The next panelist is Professor Uma Singh. She is ex-HOD and Dean, KG Medical University, Lucknow, WHO Fellow in Gynae Oncology. She is the president of UP chapter of Association of Gynae Oncologists of India, vice president of AGOI, and she is nodal officer for cervical cancer screening, master trainer for EMOC and many other things. So, welcome you, Professor Uma Singh, Madam. Dr. Neelam Mishra, she is President ISOPAP Society Kanpur, immediate past president from IMA Kanpur, immediate past president Kanpur OBGY Society. Her area of interest is minimal access surgery, hysteroscopy, infertility and menopause. And she has organized many conferences and has attended many as faculty in many other conferences. So welcome you, Madam. The next panelist is Dr. Kiran Sinha. She is Senior Consultant OBGY at Kanpur. She has served in many district hospitals, women hospitals, trained and conducted many government-related programs like SIF, PSA, family welfare programs, AIDS, medical legal trainings. Presently, she is Senior Secretary KOGS, Founder Secretary ISOPAP Kanpur chapter, and Madam is a very active member of Kanpur OBGY Society. Welcome you, Madam. Then Dr. Lata Karupati. She is at present Secretary ISOPAP Vijayawada chapter, and she is also the executive member of WOX since 2015, Treasurer WOX 2016, and Secretary. She is also a very active member, having keen interest in high-risk pregnancy and infertility. I welcome you, Dr. Lata, Madam. And so over to the moderator, Madam Sampath Kumari, Madam, for the panel.
Thank you, Dr. Supriya, for the nice words. I thank Dr. Lakshmi and the entire team for giving me this opportunity, and I welcome my panelists. They are not panelists, only discussion. All are experts in the field and they are professors. Yes. Supriya, can you see my slides?
Yes, Madam.
Yes.
Yes, perfect.
Yes. Welcome all my panelists, Dr. Lata, Dr. Neelam, Dr. Mala, Dr. Kiran, and Dr. Uma Singh. We heard all the guidelines about the adenomyosis and the endometriosis. So we had a lot of information about the adenomyosis and endometriosis in infertility. So I want to deal with the extremes of ages, adolescent and the perimenopause, what is happening. So I welcome the panelists. And first I'll start with this case. 17-year-old girl comes with complaints of pain during menstruation since 6 months. She has attained menarche at 14 years. And she has regular menstruation of 3 to 4 days from once in 30 to 32 days. And every month she takes leave for 2 days. So we will start with this patient. How are you going to evaluate this patient? We will start with Dr. Kiran. Kiran Sinha.
Yes. Yes, madam. Can you listen me?
Yes.
Hello.
Yes,
Yeah.
we can hear. Yes.
This patient, she is a girl, young girl, 17 years old, with complaining of dysmenorrhea, and she has attained menarche 3 years back. But she has got regular period. The main thing is that she is absent from school for 2 days during her menstruation. Now we have the main criteria of diagnosing this thing. We have to take the history in very detail, because there are 2 types of dysmenorrhea. It may be primary or spasmodic dysmenorrhea, where there will be no pelvic pathology, but it is related with the pain during menstruation. And there may be secondary and congestive dysmenorrhea, where the pathology, there may be pelvic pathology, And the most common cause जैसे कि अभी discuss हुआ endometriosis, adenomyosis and fibroid. So and for this we have to evaluate, and we should not forget that she may be a case of endometriosis. We should not take it lightly. क्योंकि पहले हम लोगों के समय कहा जाता था when we were young, और मदर्स यूज्ड टू से ये तो बेटा होता है, शादी के बाद ठीक हो जाएगा. जो आज भी यही कॉन्सेप्ट है, द पीपल यूज्ड टू से, इवन द डॉक्टर्स यूज्ड टू से. Then we should not ignore these things. If the girl is being absent from the school, she is avoiding all the social activities, she is not able to do her routine work, it should not be taken lightly. It should be investigated properly.
Yes, Dr. Kiran. Dr. Lata, how are you going to evaluate the patient? How are you going to confirm that she is a primary, secondary dysmenorrhea or not the primary?
Usually, through proper history, if she complains of severe pain on the first day, lasting for a few hours or so, and later on she gets relief with using NSAIDs or antispasmodics. If such pain is there, it's probably the primary dysmenorrhea. In a secondary dysmenorrhea, she might complain of pain starting prior to the start of the menstruation and lasting for all the 4 days. So if her complaint is related to secondary dysmenorrhea, we need to go for a scan and rule out any other pathology, pelvic pathology, to rule out any secondary causes.
When will you advise for scan, Dr. Lata? A girl that to 17 years doing the college studies. So now you know about the scan pictures. Nowadays, whoever the adolescent goes to scan, they will give us PCOS.
Yeah.
Okay. So when will you decide that this girl should go for an ultrasound examination?
So we'll advise her with the NSAIDs first. If she has if she gives a history of primary dysmenorrhea, and when given these NSAIDs with the only medication on the very first day, if she has a good response and further no pain, we can rest assured. And if there is no relief, then we need to get one scan done to rule out any other causes.
Anomalies. Okay. Dr. Neelam.
Yes,
what do you think about that menstrual calendar? See, the prevalence in adolescents, we are not clear because many patients, it has to be diagnosed with a laparoscope, and approximately 60% of adult women with endometriosis experienced by the age of 20. So, Dr. Neelam, what do you think about that menstrual calendar with adolescents?
Ma'am, first we have to take her proper history, in my opinion, and any previous surgical intervention, any endocrinological disorder, or any history of autoimmune disease, or any family history of metabolic or oncologic disorder. And according to her pain, like visual analog scale, how much she's having pain, scale up to 0 to 10. Then if she's having maximum pain, then which is associated with the dysuria symptoms like non-specific constipation or dysuria, all these things, or vomiting. In those cases, yes, we have to go for the ultrasound, proper ultrasound, and that can be done by a per rectal ultrasound first, explaining the patient, or first we can do per abdomen if she's or best is the per rectal. That gives a very good information about
Dr. Neelam, 1 minute. Do you think that adolescents will allow for per rectal examination?
No, I'm saying first we will go for the abdominal, per abdomen.
I think that itself is enough. Per rectal, it's very difficult for an adolescent. They need, first of all, privacy. So I don't feel that. What do you think? Other panelists, do you want to go with per rectal examination of ultrasound?
Per abdominal examination with bladder full.
Per abdomen is not for adolescents.
Madam, but deep endometriosis we cannot see with the per abdominal ultrasound. Like
Madam, these days 3D and 4D ultrasound, they are very good
3D,
totality.
4D, MRI, CT, but she is an adolescent, small girl, no, 17 years. I think it may not be suitable. Okay.
If there is no relief, we can go for proper counseling and small sedation. We can advise them.
Most of the time, the adolescents, they don't even come for gynecologist for complaint. So as far as possible, we should keep them pleasant. Okay, Dr. Neelam, proceed.
So we will see in the ultrasound about the uterus, urinary bladder, rectum, and rectovaginal septum, UV pouch,
and especially we look for the uterosrectal ligament thickening. Sometimes it is seen with the per abdomen ultrasound, but sometimes it is not seen. Then in those cases, we have to go for that. That gives the exact uterosrectal thickening, or there is any endometriosis deposit, or like in adenomyosis. In those cases, we have to go for that.
Okay. Okay. So always for adolescent, you have to elicit the history, and early diagnosis is very important. Once all of us, you know that once it is an endometriosis, they are going to live with endometriosis forever. So as far as possible,
Madam, just I want to add one thing, Madam, if with your permission, if you give the permission, that World Endometriosis Society give us a strong recommendation and instruction, Madam, during the adolescent endometriosis evaluation. History, we are taking history in our regional culture and environmental side of point of view. But when we are taking history, one history is important, that patient had any history of the neonatal uterine bleeding is present or not. If the patient's mother can give it or not, there is a source for the adolescent endometriosis. And one thing we need to find out here, there is any uterine abnormality, that is developmental abnormalities present or not.
Yes,
Madam. This two thing they are giving.
Yes, Dr. Sharmin, thank you. So we are going to maintain this, and other investigations, as Dr. Neelam told. This ultrasound, this had only to evaluate the anatomical structures. And now, as I told, now there are 3D, 4D, everything is there. With that, we can see the adnexal pathologies. And any of you, if needed, you can go for CT. Do you think, Dr. Mala, this CT is needed for our adolescent girls? Dr. Mala Srivatsa?
CT has only very limited role, because basically this girl, she has a short history of dysmenorrhea. And we think that she is having maybe a beginning of endometriosis from the history that we get, and maybe ultrasound will confirm our diagnosis of endometriosis. And we have to only in very long stated cases, or very difficult or different kind of presentations, then only we need CT, because CT is required only in cases of scar endometriosis, or maybe big endometrioma, or maybe in very if the patient has presentation in a very different way, then only we need CT in that cases. So otherwise, we can do the MRI. Maybe will be giving a more better information than a CT, especially if there is a large endometrioma and we want to differentiate what type of ovarian malignancy, ovarian tumor it is, where ovarian cyst it is, the size, the consistency, and whether it is septated or not, whether it has any growth inside or not, or solid factors or not, or there is hemorrhage inside. All these factors will be nicely given maybe by MRI in a young girl, because she's only 17-year-old.
17 years. So good UST is important. As far as CA125 is very sensitive but not specific. For this girl, it's only 2x2 endometriotic cyst. So normally you had a good talk about what are all the findings of the endometriosis: kissing ovaries, unilocular, multilocular, mobility restricted, mural echogenic foci, nodular wall thickening. So in adolescents, what are we going to focus? Our aim is to control the symptoms, prevention of disease progression, and fertility issues. I think Dr. Uma, how are you going to proceed with this patient, with this girl, 17-year-old girl? Dr. Uma Singh, are you there?
Yeah, so I am there. Unfortunately, I'm caught in a traffic. So I'll just put off my video and then try to speak. Maybe I'm connected all through or not.
You are known to everyone, madam. No need for video. You can talk.
Okay. So as you know, so as you know, this young girl with a small cyst, fertility right now is not the issue. Our main important issue is we control her symptoms and we prevent the disease progression. Both of these things are very important to us, and hence a medical management would be very appropriate. A good counseling should be there, of course, with that. Now, in that also, we start with preferably we start with just NSAIDs, and we know there are good NSAIDs where mefenamic acid and ibuprofen, naproxen, they can be good, simply very good treatment methods, good counseling, and these can be used. Of course, they would lead to decrease in the pain, they would lead to decrease in the blood flow also, just in case that is there. Keeping in mind that there are chances of gastritis, etc., this should be kept in mind, and this should be the perfect way to begin. However, disease progression, they will not stop. This we must remember, disease progression, they will not stop. And for that purpose, very often oral contraceptive pills to be given in a manner that they don't look like oral contraceptive pills, with an appropriate counseling happen to be one of the best methods to deal with, because they would ensure that the girl has kind of regular periods also.
Dr. Uma, do you want to go with oral contraceptive pills or only progesterone? Which do you prefer? This is a 17-year-old girl. Now she's
So, you know, I absolutely agree. Even though we know there are progesterones which can have a very good suppressive effect, but then we must remember with progesterones, the cycles would get, kind of delayed. They may be irregular. So either we should give a very good counseling to the girl that we will put you on that and the cycles would get irregular. There are good drugs for that also. Progesterone can be given. There is no doubt about it. As far as progesterone modes to be given, we know there are oral progesterones also, and we know there are good injectable progesterones also. So in young girls, sometimes those injectable progesterone where she doesn't have to take very frequently can also be the answer. Oral progesterone can also be the answer. Somehow I resort to, very often to combination drugs where the cycles are restored in normal way, because often the family gets disturbed if the girl does not get appropriate cycles.
Dr. Mala, what is your message about the oral contraceptive pills and the injections? Do you feel that the BMD will be disturbed by injections in an adolescent girl?
See, normally, if we can give oral progesterone and can control the symptoms, then we are happy with it. If our oral therapy is not able to control the symptoms and the patient is not very happy about it and she's still suffering, then maybe we can shift to injectables. But otherwise, most of the time in our practice, we've seen the patient do respond to oral progesterone in a very good manner.
Okay. Do you about that BMD and DMPA? Any idea?
We have never used DMPA in our practice, but I think if the patient is not responding to oral therapy, maybe it can be tried therapeutically, but we have not used it. We never had to use it in our practice.
The latest literature, they tell that previously they thought with the adolescent, the bone marrow density will be reduced, but the last per latest literature, these Antara injections are available even in the government hospitals. Okay. Dr. Kiran, what do you think about that Danazol and GnRH in an adolescent girl? For this girl, as Dr. Uma told, that in NSAID is useful. If at all needed, you can go with the progesterone.
Yes. Yes, madam. This progesterone, this should not be, Danazol should not be used in young girl. Agonist therapy, if it is used, it should be used with add back medicine therapy.
So I think for this girl, it is not at all needed.
Yes. I think only NSAID will do with good counseling, and agar mujhe dena hoga, then I will prefer, as Dr. Uma said, I will give contraceptive OCP. Because if the patient, if the girl doesn't menstruate, तो हमेशा the parents, they are very much worried कि हम तो ये करने आए थे, मैडम ने तो महीना ही बंद कर दिया. Then the whole family gets disturbed. आप चाहे जितनी counseling करो, तो मेरी भी choice शायद यही है कि I will put them on OCP. That in this case, this girl I will put it.
But we prefer to give after 18, 19 years, not for 17 years, but it can be given with the monitoring.
After 18 years.
Okay. Okay, Dr. Neelam, what do you think?
In spite of this OCs, yes, ma'am.
In spite of all these drugs, she is complaining. Only 2 centimeter endometriosis, still pain. Do you want to go for laparoscopy in this girl?
No, but there are other options. And in fact, OCs, I would like to give continuous OCs for 90 days. The girl should not ovulate. Because of the ovulation, the cyst size increases. So we should not interrupt OC. actually it should be given one by one without interrupting. So it inhibits the ovulation and that helps a lot in pain and everything. Then we can stop for after 3 months and 1 or 2 months we can see what is the response.
What do you,
I give continuous option.
Madam,
Dynogest.
what do you think about Dynogest?
Yes, I would like to give Dynogest in these cases, which is very useful, and it causes the reduction in the serum estrogen's level. It has got immunomodulatory effect. It has got the anti-inflammatory effect, and it causes the atrophy of endometrial tissue like that. So it is very effective and can be given up to 6 months or 1 year without any side effect. Of course, we have to give add-back therapy with some calcium with that.
Yes, Dr. Uma.
Moreover, liver function test is to be done before starting and after 3 months.
2 milligram minimum dose, no?
Yeah.
Dr. Uma,
2 milligram. Yeah, per day.
Uma, are you there?
She is not there, madam.
She is not there. Okay, she was telling about
No,
ossicles.
it's not connecting.
Okay. Will you go with the Dynogest alone or with Dynogest combined ossicles, Dr. Mala? Nowadays we are
getting Dynogest combined oral contraceptive pills, and it's a good option that we can try for at least 6 months with this Dynogest containing oral contraceptive pills, which give the benefits of progesterone as well as the ossicles in the both and hand in hand. So we are using 3 days. That is one of the ossicles containing Dynogest, and it is giving good results to us as well.
Yes. So the
Cost
Dynogest
effective also.
Madam, can I ask one question?
Yes,
Days
madam.
30, if we use 3 days 30 Dynogest plus ethanol, it should be, you people prefer continuous for 3 months or 1 month, then bleeding, then again. How do you prefer? How do you
I prefer with withdrawal. Dr. Mala was telling because
Even I prefer like a ossipils only we give.
Yeah.
Dynogest containing oral contraceptive pills. It is given in 21 days cycle with 7 days gap.
Yeah.
Yes.
So that
I also follow the same regime, madam. Oh.
Yes. So the laparoscopy, it is not at all needed for an adolescent. The lesions is entirely different in the adolescent compared to adult. If at all needed at the final stage, if it is needed, then as Dr. Sharmin was telling, the first surgery should be by a good surgeon, good selection, and you should have a good surgery. If you are going to do some unwanted things, then the life of the patient will be disturbed. So these are all the guidelines. Already we had a wonderful talk by Dr. Lakshmi Shrikande. See, I want to tell this college student. See, always we talk about that we should give preference to the patient. See, one of the college students, she had that grade 2, but with all the drugs, she was not able to control. But she has consulted at the gynecologist, and the gynecologist advised her surgery. But she doesn't want to have surgery. She wants to go for abroad for her studies. In that patient, we have tried with the norethistron acetate 5 milligram and then GnRH and then again norethistron. So better, it doesn't mean that we cannot compel that too for an adolescent for a surgery. Conservative management with, but this girl is now doing very well. She was diagnosed until now she is 24 years and she is comfortable, and now she is also going to get married. Why I mentioned this means you can go with this treatment since Dynogest is now available. It can be given even for 1 or 2 years. There is no complications with Dynogest. So for adolescent, as far as possible, try to avoid surgery. So NSAID, if not reduced, go with hormonal, that is the progesterone. If nothing is working out, only finally laparoscope. Now I want Dr. Neelam to tell about the Mullerian anomalies and endometriosis.
Yeah.
Dr. Sharmin was talking about this now.
Yeah. So, because there is about incidences up to the 10%, and 72% of the girls with Mullerian anomaly, they have got an outflow obstruction because the menstruation cannot go outside. It gets collected in the tube and outside in the peritoneal cavity. And in these patients, we have to undergo her IVP also, because some of these patients, they are associated with the renal anomaly like house of shapes or single step kidney. And because of the regression of disease usually has observed first the surgical correction of the anatomy. In these cases, she has to undergo surgery.
Yes, laparoscopy.
Laparoscopic directed surgery or open surgery, whatever way, these patients, they always require surgery to stop that outflow of
Yes. Now this Mullerian anomalies has increased the incidence up to 40%. So we should have
and they
in
are
mind.
usually associated with the kidney also problems,
Yes,
some
that's
horseshoe shape or single kidney like that.
That has also to be verified. So this is the point I want to tell about this Mullerian anomalies. So as far as adolescent endometriosis, first elicit the history, go with the non-hormonal medical management, then go with hormone. If at all needed, go with the gynecologist and think of the Mullerian anomalies. Finally, only laparoscopy. Now we will come to the second case. Dr. Kiran, I want to take this. This is for a completion only. So 38-year woman with complaints of pain during menstruation since 5 years, and she has completed family. Her UST finding suggestive of endometriotic cyst of 4 centimeter. So how are you going to proceed with this case? We had wonderful talk of guidelines by Dr. Lakshmi Madam. So just for completion, we will with this case also. How are you going to do with this?
Yes, madam. She is a 38-year-old woman who is complaining of pain during menstruation, most probably this dysmenorrhea for last 5 years. And the ultrasound with diagnosis of endometriosis of 4 centimeters. And she has tried many different drugs with different gynecologists.
Yes.
Then how to
all
proceed?
drugs.
Yeah. So, madam, as she has completed the family, so the fertility point is over. Now she does not want any to endometriosis of 4 centimeters. We can put her on Dynogest
All
continuous.
drugs has been tried. She is fed up with the medical management.
Then if she has fed up with medical management, then there is another option of laparoscopic diagnosis and removal of the cyst, endometriotic cyst.
Yes.
Leuprolide injections.
Yes,
Nahin.
Leuprolide, that only I told all medical managements from GNRH, everything has been. See,
But when
sometimes patient
everything
will
has
fix
been
in
tried,
mind.
then nothing is left except the laparoscopy.
So, see, sometimes patient will fix the mind only with the surgery. Okay.
Yeah.
So, in the like that, in this cases, 5 years, and she used to tell that every month I have a severe pain. So, Dr. Neelam, the lab management was done, the cyst was removed. Again, she is continuing the pain. What could be the problem and how it has to be solved? Dr. Neelam or Dr. Mala? Dr. Mala is there, I think. Dr. Mala?
Yeah. Basically, we can try LNG IUS in this case also. We can counsel the patient that maybe this LNG IUS can have some effect on the pain management of the patient, because she is persistently complaining of pain. And
yes, madam.
Maybe we can, yeah, because we have used LNG IUS in some of our adenomyosis as well as.
Voice is not audible.
Hello.
But somewhere rather for adenomyosis, we are using LNJ-US.
Yeah,
but
not for endometriosis, not
we
for
are not
endometriosis.
using.
Yeah, but this
is a very good drug. Dynogest and GnRH are helpful. Even before surgery, we can go with the GnRH.
She has already had laparoscopy.
So in
still
that
the pain is persisting. That is why I said, even after surgery.
Suppose she is not willing for LNJ-US also, what could be done? But she is having similar pain, no? This is our patient. She is our gynecologist.
And she's persistently having pain.
Having the pain.
And you have already tried GnRH, everything.
Every drug side. So finally, we did the hysterectomy. No other way. What is the point of taking only that? Many of you will not advise. Always we have to be with
it is. You have to take the patient's consent into consideration and
so
her
life. That we have to talk. The patient's importance also is important. So endometriosis affects roughly all we have done. Chronic diseases, it interferes with the sexual intercourse, bowel movements, so etc. etc. No cure for endometriosis, and treatment is usually aimed in controlling the symptoms. So,
madam, what did you do in this case?
I told you, no, we did the hysterectomy with bilateral salpingo-oophorectomy. Because already we have the lab management.
May I add, Dr. Sampath?
Yes, madam.
LNG IUS, we can also buy some time for the patient because she is 38-year-old and she has tried different medical management. She had tried her surgical management as well. Maybe we can counsel the patient and buy some time, that give at least 3 months to LNG
Yes,
IUS, and then
Hereafter
maybe
I
we
will
can buy some time.
For
That-
adenomyosis, I have used. Hereafter, I will use for endometriosis also. Anyway, we have to save the uterus. Okay.
So I just want to add here, if you
Yes,
can
Dr.
hear
Uma
me,
is
Dr.
there.
Sampath.
Yes,
Yeah.
Dr. Uma.
So, you know, very often when somebody does a surgery for endometriomas, they concentrate on just removing the endometrioma.
Yes.
A good endometriosis surgery is not just removing the endometrioma, because we all must remember endometrioma is not very painful. It is the endometriosis which is there besides this endometrioma
Yes.
on the peritoneal surfaces, especially in
Definitely.
the rectovaginal spaces, near those things. They are very painful. So a surgeon in the first attempt should not just do the removal of the cyst excision, but also must concentrate in the first attempt only on all the small parts, spots, and seen detailed, and must excise or ablate all of them very carefully, because first surgery is the best attempt, and then the pain is not relieved very often.
Yes, madam. That is the first surgery is the best surgery. That only we used to tell. We cannot going on repeatedly. One can do lap, one can do laparotomy, and then can. So since she is also a doctor, she was scared. So why unnecessarily? So finally, it is not the treatment, but to conclude, we did. As Dr. Uma said, the first surgery should be a good surgery. Before touching the patient, we should think that whatever is possible, deep infiltration, whatever is in, that has to be removed. Thank you, Dr. Uma. Dr. Uma, can you tell about the post-menopause and the endometriosis menopause? Uma is not there. Dr. Kiran?
Yes, madam.
Dr. Lata is also there, I
About,
think.
yeah.
2 to 4% of post-menopausal women are affected by endometriosis symptoms. Since there is no menopause, then they have at time. This is from the literature side. We can go with the MHT. MHT can be given, and the pain sometimes, if it is possible.
Yes, yes, madam.
Okay, then we will go with the third case of one case. This is my final case of adenomyosis. We will finish within 10 minutes. 40 years complaints of mass and profuse and painful bleeding for the past 1 year. 2 children and sterilization done. Vitals normal. Abdomen examination. 14-week size, not tender, mobile, lower border, not felt. How are you going to evaluate this patient? Dr. Neelam, are you there? Dr. Lata?
Yeah, yes, I'm
yes,
there.
Dr.
Yes.
Yes, Dr. Neelam. How are you going to proceed? What are all the differential?
Yeah, yes, I have to take proper history, and then we have to do evaluation by doing ultrasound of this patient, because in adenomyosis, there are typical findings are there, like myometrial cyst or endometrial lining, and we have to rule out also about the presence of bride or any polyp in the endometrial cavity. Like that, in the ultrasound, we can see asymmetrical myometrial thickening, or we can see linear striation or irregular infiltration of the endometrial myometrial junction zone. So by all these findings, we can confirm the presence of the adenomyosis. And of course, we have to rule out any submucous polyp or any myoma or adenomyoma is associated in this case.
But usually
and,
the
and we
adenomyotic
have to undergo her, she has to undergo like serum CA-125 also.
Yes, for malignancy has to be. So this is the way we are at structural and non-structural cases. As she told, the ultrasound features diffuse myometrial heterogeneity with hyperopoic structure, asymmetric widening of the posterior myometrial wall, uniformly enlarged, poorly defined endomyometrial interlace. Myometrium shows salt pepper appearance. You had a wonderful talk by Dr. Sharmin. So the diagnosis, we know it is an adenomyosis. Dr. Lata, how are you going to, this is a how we are going to teach the PGs? 14-week size, PA, what are all the different studies? Just for completion, you can tell one.
So we need to rule out the other causes for enlarged uterus, like fibroids. It might be the cause. Fibroids should be ruled out. In fibroids, usually the adenomyotic uterus is a little bit tender on examination, but in fibroids, this is non-tender and freely mobile in both of them. But this in adenomyosis, the intensity of dysmenorrhea increases every month usually.
Oh, yes,
And
the size will not increase, but the pain will increase.
Pain
What do you
increases.
think about that endometrial biopsy? Is it needed, Dr. Lata?
Yes, sure, madam. Before going for
Why?
any,
Will
we need to
it
rule
help
out
you
any.
to diagnose adenomyosis? This biopsy report, endometrial biopsy?
No, ma'am. No,
So
no.
we do the endometrial biopsy to rule out the other causes.
Yeah, endometrial causes, to rule out the inner lining causes. So
If the lining is very thick, then we can go for endometrial. On ultrasound, the lining is very thick, then we should go for endometrial biopsy. Otherwise, not.
Otherwise, also since she is old and to rule out that endometrial for hyperplasia cases, we are doing 14 weeks.
Yeah.
So if needed, you can go to rule out other causes, but it is not going to help with the
because they have this interrupted junctional zones are there, so better go for biopsy, rule out malignancy, endometrial malignancy.
Lata, do you advise MRI for all adenomyosis cases? We told no, this is the golden investigation.
Symptomatically and with ultrasound, if everything is proved, no need for going for costly investigations and burdening the patient.
Dr. Mala, what do you tell about this MRI?
Normally, for diagnosis of adenomyosis, MRI is not required. Nowadays, we have good ultrasound machines which can really diagnose adenomyosis in a very appropriate manner.
Yes.
So normally, we do not require MRI for diagnosis of adenomyosis.
So if at all needed, it will show. So it is not, even in our government setups, we don't do the MRI. But for completion, we are putting this MRI. The pictures will be for definition of JEZ border. So is there any other investigations? Already we have told endometrial biopsy to rule out the other symptoms only. So how are you going to proceed with this patient management investigations? Other than that, nothing, I think. Dr. Mala, how are you going to manage this patient?
Now, this patient, she is symptomatic. She is having problem, and we are also diagnosed her as a case of adenomyosis.
Yes.
CP is required if, as Dr. Neelam said, if the endometrial thickness is very high on the higher side. And of course, we have already done her LBC to rule out any other pathology in her.
All normal.
Yes, everything is normal. So we can go ahead and give either progesterone oral, or we can give her LNG IUS in this patient. Because LNG IUS will have a good effect almost for 5 years, and it will not only relieve the symptoms of the patient, will also relieve her from her abnormal uterine bleeding that she is suffering from.
Yes.
And it is going to have a good effect, local effect, and will not have any systemic effect in that patient.
Yes, when we were doing in the 90s, 91, we thought adenomyosis means only surgery. But now it is not like that. We can go with this Mirena IUCD for this patient. Mirena was given, but options should be given to the patients. That's all. So what are all the other conservative methods for completion? We can have, I think Dr. Sharmeen has covered anyway. For a role of medical management, anything, the drugs, anti-inflammatory OC pills, gonadotropin,
drugs can also be given, oral contraceptive pills can be given. Then we can also give Dynogest in these patients. Of course, we do not know like whether the compliance will be good or not, or whether she can take it for a longer time or not, because LNG IUS is going to work for 5 years, and Dynogest we are giving for maybe 3 months, 6 months, a maximum for 9 months.
So these options can be given, but LNG IUCD is the best drug. So other conservative methods, plus endometrial ablations and uterine artery embolization. Now there are the recent literatures which tells that this can be done. What are all the newer drugs? Dr. Uma, are you there? So this is the studies which tells about the ablations and any other surgery, that hysteroscopic endometrial and adenomyomar resection, laparoscopic resection of adenomyosis, high intensity focused ultrasonography. If the patient are affordable and the surgeon is very well versed with these procedures, this can be done. So the newer drugs, I think Dr. Sharmeen has covered. Anyway, I want any other newer drugs, Dr. Uma or Dr. Lata, anyone can tell about the newer drugs. This is the algorithms. Hysterectomy is the last option. The newer drugs, this only the mifepristone, Dynogest, uliprisol, low dose, letrozole. These are also has been tried, but not for this old age. But these drugs can be given as a treatment, and you can, if you don't want to go for surgery and patient is not willing for LNG IUS, these drugs can also be tried. but uniprestol I have never tried. Dynogest we have tried. The low dose letrozole now we have given one dissertation for one of my PGs for these cases. So this can be tried. For this patient, LNG-IUS is the treatment of choice. So,
madam,
yes.
Small doubt, madam. All
Yes,
these medication, can be used temporarily to buy some time. That's all. That's
Any
not
medical
the problem.
management for 5 to 6 months. If
Yes,
the patient is now, she is 42 years and the symptom is released, means if there is no bleeding, we are not going to bother about it, no? So that's the reason. All medical management only 6 months, maximum of 1 year. Unless if they are adolescent, we can go for 2 years. Other than that, we have to go for surgical medicine. So I thank all my panelists, Dr. Mala, Dr. Neelam, Dr. Lata, and Dr. Kiran and Dr. Uma. The conclusion is decision making regarding treatment is multifactorial and should be dictated by the patient's goal, whether, as I told that adolescent patient, if she want to pursue her studies, we should not compel her to go for surgery. Other medical management, and if she is comfortable, we can leave her. And they should have your life circumstances, which will be very smoothful.
Dr. Sampath, may I ask one question from you?
Yes,
आप
Dr.
अपने
Kiran.
पीजी को जो लिट्राजोल दे रहे हो, कैसे you are giving the dose of 2.5 milligram per day?
Daily.
Continuous.
Yes, yes.
For 3 months.
Daily for 3 months, 3 to 4 months. That's
Daily
all.
40. You are combining this drug with any other drug or alone litrozole?
Only
you are
litrozole.
giving?
Everything is alone. You can do some comparative study. It is only alone.
But as Dr. Sharmin was saying, mine one patient is on Dynogest plus cabergoline. And she is responding
some
very
patients
well.
will have, some doctors will prescribe all the, but as per protocols, only one drug is enough. Thank you once again. I thank the organizers for the opportunity. Thank you, Dr. Lakshmi ma'am and Supriya, Arup sir. Thank you.
Thank you, Dr. Lakshmi. So kind of you. आज थोड़ा सा पढ़ नहीं पाए
Dr.
because
Supriya
हम और
and Dr.
Dr.
Lakshmi
नीलम
madam.
मिश्रा कल तक बड़े बिजी थे IMA के इलेक्शन में.
Yes.
I must thank and congratulate Dr. Lakshmi madam and Dr. Supriya and Dr. Sampath for having me here. And we really enjoyed this panel this evening. Thanks everyone. Good night and goodbye.
Yes.
No, I am appreciating Sharmin for staying till the end. Sharmin,
Yes.
you would like to say anything?
Yes, we can get the
before we wind
opinion.
up? Sharmin?
No, madam, it's a fantastic session and the panel discussion and the panelists are elaborately, fantastically added, and which is very nice. So hope we will work together, and we need to work together the researches on endometriosis and adenomyosis in future. So I think we need to make a plan and need to work together in our region. Thank you, madam.
Thank you, Sharmin.
Thank you.
so
Thank you,
much.
Dr. Sharmin.
So, yeah. So, Supriya, yes. Sahiti, you can stop the recording and we can end the meeting. Thank you all.